Hello?
Hello, Marco.
Hello.
How are you? I'm fine.
There is an echo.
Okay, I'll just check it.
Okay, but I think that the system works.
I think so.
हेलो
नहीं इसी से आ रहा है, इसी से आ रहा है, इसी से आ रहा है. No issues. नहीं आया.
Hello? Hello?
So Marco, we can see your slides. अभी इसको बंद कर.
Can you see my slides?
Yes, we can see your slides perfectly
Okay,
well.
excellent. Okay. So it works. It's working. So I stopped my condivision. Okay, just to see if everything was okay. Excellent.
So Marco, we have a small inauguration about 15 minutes, and then we'll start at another 20 minutes. So
Okay,
you can be
excellent. Very good.
nice to see you.
Me too.
Yes. So you can.
Hello, Dr. Katoch.
Good evening, sir. Good evening.
Good evening.
How are you?
All
are
well,
you?
all well. As a,
Terrific to see you.
yeah, that's right. I'm very delighted to see you, all of you. Actually, maybe this is just in silico live for a while.
Yes, absolutely. Only two of us are together. Everybody else is.
I'm in person.
Great, great. You're in person in Lucknow, right?
Yes, yes.
He's the only person we have in the room.
I'm sitting next to Amita.
Great, great, great. I think, sir, your spirit is unparalleled. Can't really define that.
Thank you, thank you. I thought, even though it is virtual, that
Yes, now you can see us.
I should come,
No, I think that's so courageous of you. I was not expecting you here. Actually, that's very, very true.
You see, I got vaccine in December, and the second one by 8th of January. So
Okay.
I was, the day vaccine came, I got the very first day.
Oh, lovely, 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 super.
So I'm pretty okay, and I have very extensively studied my immune responses to COVID. So I know where I stand.
Great, great.
Both from T cell point of view and the B cell point of view, very specific responses. So after the first shot, after the second shot, so I have very detailed
characterization.
Right, absolutely.
Fully characterized.
So I feel very comfortable.
Great, great. Lovely.
I'm also comfortable having you around without the mask.
Great, great, great. Lovely. And how is the family? Family is all well there?
Family is all well. Ava is here, and we are going to visit Chandigarh. We are going to go to Manisha to see Manisha, and then we'll go to see Lisa in Hyderabad. So
great. So life is as normal as it could be for you.
Oh yes, absolutely.
Yes.
Thanks a lot for joining, sir. We'll get started. It's 4:45.
That's right.
And
Yes. Sure.
so to welcome all of you, it gives me a great pleasure to welcome you all to the 5th National Conference on Primary Immunodeficiency Diseases. This is a biennial event of the Indian Society of Primary Immunodeficiency. In this meeting, we are focusing on autoinflammation and autoimmunity, as I think that these two sections have taught us a lot about regulation of the immune system and what happens when the regulation goes for a knot. I hope you will enjoy the program, which has a mix of lectures, clinical cases, free paper, postgraduate program in basics of primary immunodeficiency for the students, and a quiz at the end. So I hope you will enjoy and learn a lot during these 1.5 days of our interaction. So at this outset, I would like to invite Professor Mishra, who is the Dean of our institute and is the acting director today, to give a welcome address on behalf of our institute. Dr. Mishra. Yes, Dr. Mishra, you can unmute yourself, I think. Dr. Mishra? Okay. So Dr. S.K. Mishra is just joining. So we'll just have Dr. Professor Biman Saikia, who's the president of Indian Society of Primary Immunodeficiency, to welcome the delegates on behalf of the society.
Thank you, Amita. Can you hear me?
Yes, very nicely.
Thank you so much. Hello, Dr. Gupta. How are you?
Hello. I'm fine.
So, respected Professor Gupta, our patron, Professor V.M. Katoch, who is a chief guest for this inaugural function, Professor S.K. Mishra, Dean of HEPGI, and all executive members of ISPID, the faculty, invited faculty from India as well as abroad, and dear delegates and students. It gives me a great pleasure to welcome you all to this 8th National Meeting on Primary Immunodeficiency Diseases, which is being organized by the Departments of Clinical Immunology and Rheumatology at HPGI Lucknow and the Department of Pediatrics at King George's Medical University, Lucknow, under the aegis of ISPID and FPID. There are a few firsts to this meeting. This is the first national meeting of PID in the city of Nawabs. And this is the first theme-based conference that we are having in all these years. So this is the first theme-based conference on autoinflammation, and of course, this is the first meeting in the virtual mode. So that is another first to this. And Dr. Amita has done a great job in organizing this meeting. And she's actually very lucky to have the full-fledged Department of Telemedicine, the School of Telemedicine at our institute. And this actually has proven as a boon to us because we are not planning to have this meeting on this mode, but as things turned out. And I think Mr. Ripudaman and Professor S.K. Mishra has helped immensely in this organizing this meeting. And I thank the entire organizing team for this organizing this event. And the scientific program looks great, and Dr. Amita and the entire scientific committee has put up a very excellent program. And we're going to have an academic feat in the next 1.5 days that we're going to have. So I'm sure we're going to have a great meeting, and I wish you all the best. Thank you. Thank you for joining this meeting, and enjoy the academic feast. Thank you so much and welcome.
Thank you, Dr. Viman. Good to hear from you. And I would like to invite Dr. Sudhir Gupta to say a few words of encouragement, as he is actually the soul behind the whole PID movement in our country. So no meeting is complete without him.
Absolutely.
Thank you. Thank you, Amita. First, I must thank Amita for putting together this virtual meeting. It's not an easy job to put together any meeting for that purpose. And I also like to thank the speakers, all the speakers from US for accepting my invitation. And as you can think, the theme is autoinflammatory diseases. By definition, they are not immunodeficiency. There is no immunodeficiency in it. And that's why there's a trend now, there's a proposal, and we'll be following that they will be called the inborn error of immunity rather than primary immunodeficiency diseases. So slowly we will transition it. One of the interesting thing is we are celebrating a decade of primary immunodeficiency really in India, because 10 years before that, the FPID was started about 11 years back, and soon after that, Indian Society for Primary Immunodeficiency were established. And you can imagine prior to that 10 years, there were about 37 papers on primary immunodeficiency diseases which were published from India. And since then, in 10 years, there are more than 400 papers have been published. So this just gives you the landscape of the primary immunodeficiency diseases in India is totally changed, to the extent one of the very leading, perhaps the best and the most leading journal online for immunology, that is Frontiers in Immunology, requested us to put together a special research topic of advances in PID in India. And we have put together those, and it has been incredibly a true collaborative effort, because each of the paper, if you see, there will be at least 20 different authors. So everybody who is involved, everybody contributed to those papers. And Dr. Sobha Saigal and I'm co-editing it, and it will be put together as an ebook. So I am so pleased, and all the credit, I'm just a little catalyst in it. All the credit goes to the director of FPID centers that we have in India. So again, the program is terrific. I'm sure you'll enjoy it, and everybody should enjoy it. We have who is who in the field. So I wish you all the best and enjoy and learn a lot during this next 2 days. So good luck.
Thank you, Dr. Gupta. And as we were just talking of Dr. S.K. Mishra, he had some issues at home, so he is just coming and joining us here in the boardroom. So till he joins, I would request Dr. Katoch, who is the former Director General of ICMR and previous Secretary to Department of Health Research, and who has been the pillar of strength in developing the ICMR supported PID centers in our country. And I think that has given a big boost to diagnostics as well as the care of patients with primary immunodeficiency. Good, we can see a youngster there. That's nice to see him. So I would request Dr. Katoch, who's been associated with every meeting of this society, to give us an inaugural address.
Namaste.
And
Namaste, namaste.
namaste.
Professor Sudhir Gupta, Professor Sekia, Professor Agarwal, and Professor Mishra, I couldn't talk to you, but anyway, my grandson has greeted you all. So now these are the days I'm in Bangalore, staying with a daughter for 2 weeks. And it's a always, great opportunity to be associated with Professor Sudhir Gupta, because, in 10 years, this movement has built in so well. I mean, because for me, every year I saw the progress happening. More people getting connected, more departments getting upgraded, having the capacity to do investigating the PIDs. And even I remember, the first address which we prepared for the minister 10 years back, the number of the PID has gone 300%. They were not identified even at that time. And I think internationally, the movement has built up, but the nationally movement also has grown. Courtesy, of course, the basic Atma has the spirit has been Professor Sudhir Gupta and his family. But then a lot of friends he created right in Chandigarh, Mumbai, Lucknow, Kolkata, everywhere, Bangalore, and every city actually. They have created the nuclei around them. Some nuclei have not progressed the way they should have. I'm very frank, honest on that. We expected that, but they really didn't carry forward. But they had the opportunity, they should do it. And the others have done extremely well. I think that since last meeting, I'm talking of one thing only. Now with this much knowledge already emanated, and already the goal for which Professor Sudhir Gupta created this movement, I remember the very first meeting, it is to empower the country actually, his country of his origin, that the cases are detected early. That means the access, first it was the empowerment in terms of the mindset change, investigative science, which the tools were there, but they were not being used actually. But secondly, coming out the access of this technology to the people across the country. That was his spirit, which in 10 years, it is available. But I think this is now the time to come out with the India-specific guidelines. Because that's which infections you detect in India and how they are different than what you get across in other places of the world. Because the genetics, the environment, everything has its own variations. I think this is now the time not of talk of the similarities. This is time to talk of both the similarities and dissimilarities. And I think this is the 1 decade after the progress. I think all the participants, particularly from the India and also the international friends, who have been the link that has been again Professor Sudhir Gupta. Though this is the time to look at the variations. That's the novelty in science. So access, similarities, dissimilarities, access of technology, access of the services. I think there again, many things has happened. Mostly, many times it came from his own personal funds, the funds from his foundation. But then, so many state governments have woken up now. Then the courts are intervening. But once you have guidelines which are acceptable, there are India-specific guidelines coming through the edges of this society, which will have a legal sanction actually. That's the time to, I think, now to think about, because that will make something, the translation of his dreams to the reality actually. And for me, this 10 years of journey, I've been very delighted because I don't work on that actually. But at the same time, I've been a promoter. First, I joined as something motivated by Professor Sudhir Gupta, but then my own personal emotional attachment became to the cause because I saw the suffering happening across and the ignorance. I think that they all moved me. So I'm very delighted to see what has happened. But at the same time, I'm looking at now the consolidation of the efforts so that the access to the knowledge, access to the services, access to the amenities, that becomes a reality with the dream with which this whole movement started by him. But then it had a strong Indian groups which joined in. They have immensely contributed to the cause. But I think I'm looking at this against conference proving as a landmark from that perspective, and something concrete happening in terms of the easy to use India specific guidelines, which I think carry forward the movement. So I'll convey my greetings to all of you who are participating. Professor Sudhir Gupta, Professor Amita, I'm seeing, Professor Viman Sekia, I'm seeing on the face. Professor Mishra, I'm also seeing now. But then actually, of course, I greet everybody. The international friends also are there on the screen, but others, many of I will not be able to see them. But I'm sure, this will have a strong connection across the country and also across the globe. So I wish everybody good luck. See, COVID has disturbed everybody for a while, but I don't think that the movement will slow down anyway. So wish you all the best actually, and looking forward to, I think, next year again with something stronger, more solid, and something which the Indian systems adapt and translate. The others also start owning. That's the step which you have to move on. And so, greetings to all. Greetings to Professor Sudhir Gupta, Professor Agarwal, and Professor Mishra, of course, with Professor Sekia and all the people who are today leading the movement by this society, and of course, partnering with the foundation of the Dr. Sudhir Gupta also. I think that's a warm wishes. Wish you all good luck. All the best.
Thank you. Thank you, Dr. Katoch, for your words of wisdom. And we hope we live up to that in the near future. And now I'll invite Dr. S.K. Mishra, who's the Dean of our institute and is the acting director today, to just say a few words and welcome the delegates on behalf of our institute. Dr. Mishra.
Thank you, Dr. Amita. So greetings from our institute. And I must compliment to the Department of Clinical Immunology and Rheumatology for hosting this event. Professor Gupta, he has been meeting us and visiting our institute many times. I had the opportunity to interact with him. So we are privileged to have you, sir. Professor Biman Sekia, who is very well known to me, and he is now currently the president. And Namita, of course, very dear friend, and we've been interacting with on so many for us in the institute. And I really appreciate Namita to take over this responsibility of organizing this event. I could see there are 90 odd participants, and many of them are esteemed faculty from overseas. The topic is such where many people are interested. And Professor Sudhir Gupta is the instrumental in connecting all the dots here and there all over the globe and bring them here in this forum. Fortunately, unfortunately, COVID has made us to participate more kind of privileged environment without spending much money traveling and etc. And finding out some time to interject this kind of academic exchange. I just want to tell all the esteemed faculty from overseas who are not familiar with our institute. Sir, our institute started about 32 years ago, almost you can say 35. If you talk about decades, we have crossed 3 decades. We started with concept of a tertiary care institution. Professor Katoch, Professor Gupta, you must be knowing the foundation of the institute, how it started. A lot of debate went on, should we have a super specialty institute exclusively? After experimenting postgraduate institute in Chandigarh, then the next experiment was the Sanjay Gandhi. And if you are involved in the initial concept, interacting with our forefathers, and today, I think you must have realized those dreams of those our forefathers have fulfilled, I think, the vision, what they envisaged. Many of them are not there in our institute currently. Professor Agarwal, I think many of you must be knowing him. He's a giant personality, and he has been contemporary of Professor Katoch and Professor Gupta, and how much he was very kind of keen on subjects of this entity that we are discussing today. And because of him, today the department that stands on his great shoulders. So we must remember him at this juncture, that how much he has contributed to our institute. So with the blessings of our forefathers, we have come out to this long way. And I'm happy that Amita has taken over this mandate of fulfilling the vision of Professor Sudhir Gupta to see that this area of research expands in our country, and he has been able to make friends with many institutions in this country and supporting both financially, morally, and whatever way he can do it. not only in our country, in many of the developing countries also he has been working. And this is the area which became very popular during AIDS time, and it is also become popular because of so many other entities that has been discovered in the recent times. And this is a forum where the pathologists and the practitioners and the basic researchers, they get together. So I wish this event a success in terms of academic interaction. Do visit our institute whenever you have opportunity to any way you attend this meetings or friends or visiting this institute. Thank you all for making yourself available for this academic exchange.
My pleasure.
Yeah, thank you, Dr. Mishra. And at the end, I would like to thank everybody who has helped me at different times to organize this meeting. And I won't take much more time. And I hope you all enjoy the meeting. We have about 200 registered delegates, 100 have already joined, and people are just joining soon. So we'll set the ball rolling for the academic feast to start. And the first lecture in this series is by Professor Marco Gotarno from Italy and Dr. Sujata Sani, who's consultant pediatric rheumatologist at Gangaram Hospital in Delhi, is the person who's going to introduce Professor Marco. So over to Sujata.
She has not unmuted.
Sujata, you'll have to unmute yourself.
Well, I saw she unmute.
Sujata, can you unmute yourself?
Yeah, thank you for that. I was not able to unmute thus far. So good evening, everybody, and a very warm welcome to Professor Marco Gotarno. Marco is very well known to many of us. Marco is a pediatric rheumatologist and immunologist and a dear friend. He's the head of the unit for autoinflammatory diseases and immunodeficiencies in Gasolini in Genoa. His main scientific interests revolve around monogenic autoinflammatory diseases. He's the author of more than 250 papers and also several book chapters. He's the editor of the book Familial Mediterranean Fever. Additionally, he's the principal investigator for the Euro Fever project and is currently the president of the International Society of Systemic Autoinflammatory Diseases. So over to you, Marco. Thank you so much.
Thank you very much, Sujata, and thank you, Amita, for the very kind introduction and invitation. It's a great pleasure to meet you all. Just a moment. Okay. I start the presentation.
Yeah, you'll have to just share your presentation.
Yeah. Okay. I hope that now.
Yes, we can see it.
Okay. Do you see?
We see your screen, not your presentation. Yes, now we see it.
Okay, very good. So thank you very much, Amit, again for the kind invitation. It's a great pleasure to meet all of you. I'm looking forward to meet in person because I've never been in India. So I hope that we will meet around the world, but at a certain point come to find you because I'm following very, very close how the situation is expanding in India related to autoinflammatory disease. I had the honor to be part of the effort of your effort on collecting the data on autoinflammatory disease in India. I think it's a fantastic opportunity to work all together, and thank you to give me the opportunity today to, let's say, tell you about our history, what we did in Europe for this field of rare diseases in the last 10 years. These are my disclosure. I have to say that the Eurofever Registry had some restricted grant from Novartis and Sobi. That was very important, of course. This story started from some years ago when we were able to obtain a grant, a European grant, in the field of rare diseases. At that time, as you can understand, the autoinflammatory disease was just at the beginning, and it was clear that the field was increasing a lot in terms of number of diseases and so on, number of patients, but indeed very rare diseases. And so we came out to the idea in Europe, in the Pediatric Rheumatology European Society, the Press Society, that in the working group for autoinflammatory disease, at that time I was the coordinator for the working group, that would be very important to have a common registry to share experiences on these rare diseases. And that was the case, and we built up a registry. We decided to build up a registry in which all the diseases could be included. I just briefly go through just to see that, of course, in the registry you are able to include, of course, the demographic features, and there is a growing list of diseases. So we start with just 12 diseases at that time, but now every year we have to include many other conditions, and of course a lot of genes with all the variants that we are getting directly from the InFever database. And we decide, even if this could be a little bit tricky, to indeed have a registry that is rather detailed. So you can see here that there is the possibility to go into detail in the possible manifestation. So the idea is to try to give a good idea on indeed what the patient has. We have now also, in the first part of the registry, was a cross-sectional registry in which we collected the information from disease onset to the inclusion in the registry. But now we became more ambitious, and I will show you some example. And now the idea is to use the registry to follow our patient in a longitudinal way, because this is the only way to really see in an observational study how we can treat, how the treatment that we give to our patient behave during the time, and also underline the safety and efficacy in the long run of this treatment. And so also the adverse events and so on. This could not be possible, as you know, without the incredible, let's say, organization of Printo, that is, as you know, is held in Genoa, in my institute, and run by Nicola Ruperto. And of course, thanks to Printo, that is the technical arm of Eurofever, we were able to reach the big Printo community and to reach a lot of centers that have very rare diseases and very rare patients. So we started the adventure in 2009. Now we have more than 11 years, almost 12 years of life. And at the beginning, we were a little bit worried on the possibility to recruit patients. And indeed, now the results, it's really important. We have more than 4,050 patients with the different autoinflammatory disease, monogenic and also multifactorial. And you can see here, of course, Western Europe and Central Eastern Europe. Europe is the most, let's say, represented part of the world. But of course, we have several patients from Southern Eastern Mediterranean countries, South American, and some patients also from other countries, a lot from Armenia, and also some patients from India. And I hope that everyone can also participate in this international effort if you want. Of course, you are more than welcome to include also in this international registry your patient to collaborate in an international way. These, of course, these are the most relevant disease, a relevant number of patients. You can see here patients with different conditions, multifactorial and monogenic. And of course, it's interesting to see where the patients are, how many centers see patient, and which is the demographic distribution of the different disease, also the impact, the numeric impact of the different condition, rare condition. But of course, what is more important is to try to understand and to study something new, and to address some questions. And so what we have learned in these last 12 years, what we have learned is published. And we had the lucky, we were lucky enough to have a number of publications on very good journal, I have to say, in the field of rheumatology that, let's say, I hope help the community, the world community in the world, to have more insight in many aspects of autoinflammatory disease. And we collect a huge number of patients, and I tell you some example. I will go very quick, just to not, I will not go into detail in this published paper, but just to give an idea on the philosophy and what we did in the first years. The first paper was done by Natasha Toplak, that from Slovenia came to Genoa to analyze the first data some years ago. And it was very interesting to see, for example, at the very beginning, the first paper on the delay of diagnosis in our diseases. This is something that I'm sure you are facing the same problem. And it was clear that there was a clear delay of diagnosis. You can see here the age of onset and the age. Sorry, I have to go. Okay, here. Okay, maybe here you can look at my arrow. You can see the disease onset and disease diagnosis, a huge delay. And of course, we were able to reduce this delay according to the decade of birth, but there is still a relevant delay in our capability. And that has been improved a lot. These are unpublished data for the four main autoinflammatory diseases. You can see here in the first years of the registry, we had a mean delay of 7 years in the old patient. That has been reduced a lot to 1 year, 2 years in the last 7 years. That means that the community starts to be, thanks to the different initiatives, start to be more aware of this condition, and also the possibility to have genetic tests more easily really help a lot. And so we are doing, I think, a good job in terms of recognition. And so I give you just a very quick, brief idea on how we proceed. So the idea in the registry is that everybody that include patients in the registry can ask and can propose a study, and can propose and can have the data from the registry to analyze the data according to a given project. So this is really open to everybody that is included in the network. And so the philosophy is to share data and to make this data availability to different researchers and colleagues. For example, Ceza Ozen were able to understand how in pediatric FMF is the distribution and the severity of the disease, and she was able to understand that indeed the environment and living in Turkey or South Mediterranean country give a burden of the disease, also in the pediatric patient. Terhar and were a student from the Netherlands, was able to start to study the first data coming from the treatment in this patient. This is a paper that has been cited several times, and give the first idea in a bunch of patients on the different treatment throughout the registry. Helen Lachman, as you know, a great expert of TRAPS, could take advantage of the first and larger registry on TRAPS, and described in this paper in Ulmus rheumatic disease the difference between adults and children. again, Bénédicte Nevin in France were able to identify and to describe the first cohort, a larger cohort of CAPS patients from the Eurofever registry, like Jos Frenkel, again from the Netherlands, the cohort of hyper-IgD. So, I mean, that was quite interesting to give the possibility to all the colleague. This is Hermann Dirkeschick from Germany, that at that time, some years ago, described the largest area of chronic recurrent multifocal osteomyelitis. Of course, I don't go into detail in this paper because they are available, but just to give an idea of the philosophy and also of the registry, and also of the fact that you have to provide good evidence and good clinical manifestation, good data to provide valuable, let's say, information on the different clinical manifestation of the disease and so on. Then another aspect coming from the registry is the possibility to have some new clinical insights and also tools for the diagnosis and the management. This is rather important. One tools that we created thanks to the Eurofever registry and in collaboration with Isabelle Conepo in Paris was the elaboration and the validation of a score that you know is the only score that we have for autoinflammatory disease, that is IDI score. This is was performed in collaboration with and validated with the Eurofever registry patient. And also we provide, these are two residents of mine, Riccardo Papa and Matteo Doglio, that were able to identify a sort of web-based collection of the genotype-phenotype association. This is online, and they did an incredible job. Some tables, I don't know if you can see, and they describe for each disease, this is for TRAPS, for example, for each mutation that has been, let's say, included in the registry, you can go to the table of the also online and also link it to the Eurofever website, and you can see how many patients has been described in the registry, which were the clinical features and the response to treatment, and also some complications. So if you have a given genotype, you can go there and to see the other patient described in Eurofever, how they behave. So that could be of some usefulness. Also, Erkan Demirkaya from Turkey, now in Canada, was able to propose a very interesting, let's say, project in which he was willing to validate and to see the accuracy of the different criteria, diagnostic criteria for FMF. And what he observed that indeed, when we were able to identify, let's say, verify these criteria in a context of different diseases, different, let's say, also population, the accuracy of these criteria were not that high. And this was really an important point, because the great advantage to include in a single registry all diseases in which we, let's say, collect the information with the same information, with the same clinical manifestation, it's rather important, because that means that we can, let's say, make a confrontation and make a study to see if there is indeed the possibility to distinguish one disease from the other, and which are the clinical manifestations that really are specific for one disease in respect to the other. And so what we did for the first step, together with Silvia Federici in our group, we set up a first proposal of some preliminary classification criteria for periodic fever, based on the statistical combination of real patient, so not on the judgment of expert, but on the data coming from the multivariate analysis from different experts. And she was able to establish the first preliminary criteria. Then we went on, and as you know, we had a very, let's say, ambitious project to build up new evidence classification criteria, with the help in this way also of many experts from all over the world. And this was a very important and very difficult task, a very long task that involved a lot of experts, geneticists and clinicians, and with evaluation of true patients from the registry and the judgment of the patient, and also the statistical analysis for the choose of the best classification criteria in terms of accuracy. That was a great project, again from another project founded by European Union, and that has also a parallel project, very important, taken care of, that was taken care by our geneticist, that was to establish the pathogenicity of all the variants that for autoinflammatory disease that has been included in the InFever database. So there was a huge work from our geneticists to try to classify all the variants described in InFevers in clearly pathogenic, likely pathogenic, variants of unknown significance, or benign variant. That was a great job. And at the end of the day, these are, as you know, published very, let's say, quite in 2 years ago, the new classification criteria coming from the Eurofever registry. And for the first time, we have some criteria that make together, join together the genetic, the clinical feature more related to each disease, and the molecular analysis. As you know, all the diagnostic or classification criteria so far were just clinical criteria. That was a little bit of nonsense, that the genetic disease do not have also the genetic test as an important factor. And in these new criteria, you can see here, there is the possibility to include the genotype and also the clinical features. These are the new PFAPA criteria that has been described with this system. And the other aspect, as I told you, was the classification of the variants. This is important because this is the paper coming out from this project, and this is what you can find now in the InFevers database. You know, the InFever database is very important for everyone that is working in the field of autoinflammatory disease. You go to the database and you can find the different mutation that has been described so far for each disease. And now you can find also the pathogenicity. So there is the judgment among the experts on the level of pathogenicity of each condition. This is very important, of course. So the combination of clinical criteria and genetic criteria is very important to establish the real classification of the patient. And this is a very recent paper that we published some weeks ago, again in collaboration with Ellen Lachman, that was the main investigator, and on traps. That was a very good exercise to see in a large, I think the largest cohort of traps patients ever published, more than 226 patients with TNF mutation. We wanted to see how they behave according to their genotype, according to the classification. You can see how many variants we were able to identify, and we let's say we divided the patient in different subgroups: patient with pathogenic variant, patient with VUS variant of unknown significance, or patient with benign or likely benign condition variants. And what was quite interesting, I hope you can see, is when we combined the possibility to fulfill the Eurofever criteria with the genotype, you can see here, if I am able to use again okay, here, you can see here that if you, in the real life, patient for real life, you can divide on the fact if they fulfill the Eurofever criteria or not. I'm sorry. You can see here that the behavior, in terms of behavior of a clinical response to the treatment, is rather different, because you can see here, for example, that in this group that has a pathogenic mutation, all the patients respond quite well to anti-IL-1 treatment. You can see here. I'm sorry, but okay. You can see here. All patients respond quite well, complete response to anti-IL-1 treatment. The same are for those patients that have variant of unknown significance but fulfill the Eurofever criteria. Most of them respond very well to anti-IL-1 treatment, but it's not the case to the patients that do not fulfill the Eurofever criteria. They use much more colchicine. For example, the patient with R92Q variant that respond less well to anti-IL-1 treatment and also to anti-TNF, and they respond much better to colchicine. So that means that this population is rather different from the classical population of traps with pathogenic mutation. And so we have to really, we show that we have to really pay attention to the significance of R92Q or some variant with low penetrance.
Sorry, Dr. Marco, I'm so sorry to interrupt. We are coming close to time, please.
Yes.
Thank you.
Yeah. Just the last 3 minutes. And so I mean, the example here is also we started to have the longitudinal registry, and I have to say that the longitudinal registry, the study of the longitudinal registry is very interesting. I do not have time because I have to go quickly. I thought that I had 30 minutes, but I go quickly just for the discussion, I think, and I will go quick. And this is a first example of the longitudinal study that we are doing, and the granularity. For example, our idea is to see how is the impact of colchicine in FMF in our Italian patient using the Eurofever registry. So the idea is also that you can use the registry also for national study. So if you want to, for example, we decide in Italy to use the platform of Eurofever also to have national study. That give you the example of how the granulosity that you can obtain. For example, with the longitudinal study, we can see how many patients are in complete response, in complete control of the disease with using colchicine, how many of them are still some episode, one episode for a year, for example, or more than one episode for a year that is colchicine resistant. And also you can see also the colchicine dose, because you know that the colchicine has to be start with a given dose, and then that are reported here, but the recommendation say that if the patient do not respond, you have to increase the dose of 0.25. And using the registry, we were able to understand that many of the patients, especially children, that do not respond properly, that still have fever episode, are undertreated. So they did not, let's say, increase the dose. We keep the dose low. And so I think that this is an example how the registry can help. So going to in conclusion, I think that I hope that I show you how the registry can provide information, can have an impact on the general knowledge of our diseases. This is the number of publication, number of co-authors, and the total citation that we have, the impact of the registry that is still ongoing, give us the possibility to analyze rare diseases and compare different conditions, give us the possibility to elaborate evidence-based classification criteria, and the recruitment, of course, is still ongoing, and there will be new diseases, and the longitudinal part will be very important. I thank all the people working with us, of course, in Genoa for this huge, and all the collaborators around the world, because, of course, this is a public and general effort. Thank you very much.
So, Sujata, are you there?
Muted.
We don't have time for question and answer.
Thank you, Dr. Marco.
Thank you.
I think Sujata is there. Yes, Sujata. Sujata, can you unmute yourself? Sujata, you're muted.
I don't know what she's doing.
Sujata, you're muted. So,
Right, Amita, thank you for that. Amita, sorry, the system doesn't allow me to unmute.
okay.
It locks the muting. You cannot unmute it yourself. So somebody has to do it from the back end.
Okay.
So Marco, thank you so much. That was an absolutely excellent presentation. Amita, do we have time for any questions?
If there are any questions in the chat box, you can take them.
I don't see any.
There
is one question from Dr. Sapan. Since this is an expanding area, Marco, how do you plan to include patients with new manifestations?
And is referring also to the VEXAS syndrome. That is very important. Absolutely, yes. I mean, the idea is every year we have a commission that analyze all the new diseases and let's say modify and update the registry in terms of the number of the diseases on the genes, and also to increase the clinical manifestation. So for sure, in the next year, we will include also VEXAS. That will be very interesting, of course, because it's a new disease and we have to understand more. Sorry, this is just to know that this is not just for pediatrician. Is a registry that is open to adult centers. So we have almost 25% of our patients are adults. So this is and since VEXAS is an adult disease, would be also important to add it in.
So thank you so much for that, Marco. I'll hand back over to the organizers. Thank you so much.
Thank you very much.
Thank you, Sujata, and thank you, Professor Marco, for a wonderful talk. We really enjoyed, and it will give us an impetus how to go about in India when we are starting to make our registry, and your comments are valuable in that. Thank you. So we move on to the next session. The next session is going to be chaired by by Dr. Anju, Professor Anju Gupta from PGI Chandigarh, and by Dr. Amreen from Wadia Children's Hospital. I'll just share the screen, and this is a very important session for all of us because this involves our students and they are our future. So over to Anju and Amreen.
Good evening, everyone. As a clinician, we all learn from cases and more so from complex ones where clinical medicine sometimes just doesn't help and genetics helps in diagnosis. And it also forces us to go backward and see where we committed mistake or how we could learn further. So with this, we have 8 cases coming up in this session. Dr. Ashish will be presenting the first case. Dr. Ashish, please.
Dr. Ashish, can you start?
Yeah. Am I audible?
Yes, perfectly.
Yeah.
So you have a ring at 5 minutes.
Yeah. Good evening to all. Today my topic for case presentation: childhood onset of autoinflammatory disease due to a novel mutation in TNF-IP3 gene. Next slide. This is a 7-year-old boy, second born to congestionous parents, presented with a complaint of recurrent episode of high-grade fever with chills and rigor associated with oral ulcer and polyarthritis since 6 months of age. He also have a recurrent episode of loose stools that were pasty to watery in consistency, almost 3 to 4 episodes per day since 9 months of age, and have a recurrent cough with episodic breathlessness since 6 years of age. For this above complaint, he was diagnosed to have a persistent asthma and juvenile idiopathic arthritis. For that, he received a trial of steroid along with immunosuppressant, and he is on at a time of presentation on inhaler, including budesonide and salbutamol. His antenatal and perinatal history was uneventful. He born with a birth weight of 2.7 kg. He achieved a normal developmental milestone till age, and he was immunized, including the live vaccine, till 10 months of age. Next slide. Yeah, clinically, he presented with a very weak and lethargic, with growth retarded, having a height of less than 58 percentile with weight of 3 percentile, having a generalized lymphadenopathy, including a cervical, inguinal, and axillary lymph nodes that was subcentimetric, and have a polyarthritis, including right ankle and bilateral wrist joints. For above findings, the differential considered were infections, including disseminated tuberculosis, hematological malignancies, including and SLE-like features like and inflammatory bowel disease. For infection, including disseminated tuberculosis, his workup was all negative, including blood culture, stool workup, and workup for infectious disease like enteric fever, ectational disease, malaria. And TB workup include from the gastric juice, lymph node biopsy, and bone marrow were negative for expert TB PCR and MGIT cultures. And his hematological analysis, bone marrow was done with a normal hematocellular marrow, no any abnormal findings in the bone marrow. And autoimmune markers, ANA and complements were all normal. Our rheumatoid factors was negative. Inflammatory bowel disease, that one was considered because patient presented with recurrent episode of loose motion. Initially, his fecal calprotectin protein was positive, almost 117. For that, he underwent GI scopy. His gastric mucosal endoscopy find a mucosal thickening was there. For that, patient underwent biopsy, which has some which has some chronic inflammatory changes at the in gastric mucosa, duodenum, and in colon mucosa. Next slide. For that, for this blood investigation per se, his blood counts were all his peripheral blood counts are all almost normal only, with the differential in lymphocyte over 19%. History of some absolute lymphopenia with absolute lymphocyte count of 798. Virus serology was negative for HIV, HBV, HCV. Blood chemistry was almost normal only. Serum immunoglobulins, he has a hypergammaglobulinemia. Sometime in autoinflammatory disease, patient may have IgG in higher side, with other immunoglobulins were on normal range. In lymphocyte subset enumeration, that was all almost normal with the lower side of normal range. So till now we have no any definitive diagnosis for this child. We proceed with NGS. NGS suggests some heterozygous mutation in TNFIP gene, which was confirmed by Sanger sequencing. So recently, in Journal of Clinical Immunology, a publication was published that a study of heterozygous mutation in TNFI3 gene have been found to cause a haploinsufficiency of A20 protein, which was involved in NFKB pathway and may cause some early onset of autoinflammatory disease. So this child was diagnosed to have an autoinflammatory disease with a novel mutation in TNFIP3 gene. He was started with a prednisolone with 1 mg per kg, with which his symptoms were subsided. His growth has improved, and CRP and fecal calprotectin protein was all normalized. So currently he in last follow, yeah. So currently in last follow-up, he was on antimicrobial prophylaxis in December 2019. That time his TNF3 gene, that NGS report was not available. So the question for this case presentation is that, so how long, if we give steroid or antimicrobial prophylaxis, how long we have to continue in this mutation, and is the definitive treatment in this type of mutation is stem cell transplant? So this has to be answered. Yeah,
Thank
these
you,
are
Dr.
all.
Ashish.
Yeah. Thank you.
Thank you, Ashish. Very well evaluated. We've got one question for you from in the chat book. Are the parents asymptomatic? Were they tested?
Parents was not tested, but the parents were not tested, but they are asymptomatic with the child at the time of presentation, with no any history of similar complaint in their.
Okay. There's another question there for you. Why did you prefer prednisolone?
Sorry.
Why have you not preferred colchicine?
Protein expression.
Why we have not considered colchicine? Actually, we are suspecting a autoinflammatory disease, so we proceed with a steroid only. We are not aware that colchicine will work or not. So from our side.
Thank you. I think we should proceed with the next case.
Yeah.
So Dr. Umair Bargil is going to present a patient with a novel mutation in PLCG2.
Good evening, everyone. Am I audible?
Yes.
Yeah. So the title of my case is Atypical Presentation with Incomplete Penetrance in a Family with Familial Cold Autoinflammatory Syndrome. Autoinflammatory syndrome due to a novel mutation in PLCG2. A 17-year-old female born out of a non-consanguineous marriage presented with history of angioedema urticarial rash almost every month since past 6 years. The urticarial rash was exaggerated on response to cold, and it responded to antihistaminics initially. The severe episodes required danazol and FFP transfusion. The danazol helped in reducing the frequency to a limited extent. Her episodes continued and worsened during her pregnancy when the danazol was stopped. She required FFP transfusion once per month during the first trimester, which increased to once per week in late pregnancy. Postpartum, the rashes, she developed rashes all over the body, vomiting, abdominal pain, and dyspnea every 7 to 14 days, requiring intermittent FFP transfusion and restarting of danazol and tranexamic acid. She still had difficulty in swallowing, breathlessness, rashes, and intermittent angioedema, so she was given a trial of omalizumab, to which she developed anaphylactic reaction, warranting hospital admission. Her urticarial rashes resolved post-omalizumab, and her father, who recently developed stroke, had a history of repeated lip edema, which resolved on symptomatic treatment. So the differential diagnosis based on the clinical history can be hereditary angioedema due to either congenital or acquired cause, or inflammosomopathy due to mutation in NLRP3, 12, or PLCG2. Her C1 esterase, C3 and C4 levels were normal, making hereditary angioedema less likely. Her immunological workup showed normal B cell numbers with elevated memory B cells and class switch memory B cells. She also had very low plasma blasts. She had low IgG and IgA with normal IgM and IgE levels. On clinical exome sequencing, a novel heterozygous missense mutation was identified in the PLCG2 gene, which was located in the Y box domain. The in silico analysis suggested that it is pathogenic by the SIFT, ClinPred, and REVEL, and had very high CAD scores. Both her parents were carrier for the same mutation. So here we report a case of familial cold autoinflammatory syndrome type 3 due to a novel missense mutation in PLCG2. An overlapping phenotype with the PLCG2 associated antibody deficiency and immune dysregulation with hypogammaglobulinemia and low plasma blast. Though she had hypogammaglobulinemia and low plasma blast, she does not have recurrent infections. The index is symptomatic, with the father having minimal symptoms and the mother being asymptomatic. So this suggests that there may be an incomplete penetrance in this family. To understand this, further studying of gene expression downstream of PLCG2 may increase our understanding about the incomplete penetrance and the varying phenotype of this disease.
Thank you, Dr. Omer, for clarifying a lot of issues. For a clinician, important thing is how do you differentiate this cold-induced urticaria and angioedema from acquired cold urticaria? Here, you did have a positive family history in the form of father being symptomatic. So hereditary etiologies obviously would be more likely. So could you tell us how you differentiate between acquired and genetic etiologies of cold-induced urticaria?
And whether it is histaminergic or non-histaminergic. So depending on the clinical history and the C1 esterase levels, the C3, C4 levels, we initially tried to look whether the hereditary angioedema, whether the hereditary angioedema is there or not. Then with the strong clinical suspicion, we did the clinical exome sequencing to identify any mutation, whether any mutation is present. So this patient had a mutation in the PLCG2 gene, and the other genes, there was no any other likely pathogenic or pathogenic mutation in any other gene. And we tried to further investigate. The PLCG2 has 3 phenotypes: the autoinflammatory associated one, the antibody deficiency one, and the third one, the familial cold autoinflammatory syndrome type. That might be the case with this patient. So we did the workup we did the extended B cell immunophenotype, and the immunoglobulin levels, they were consistent with the antibody deficiency kind of a phenotype.
Dr. Omer, there are a few questions. One question is, what was she treated with?
She was initially given danazol, though the frequency reduced, but she still had recurrent episodes. Ideally, in a case like this, they should be given a trial of either anakinra or canakinumab. Unfortunately, they are very expensive and not available in India. So she was also given a recurrent FFP transfusions, to which she responded. Post delivery, when she had very severe episodes, we were advised to give her a trial of omalizumab, though her IgE levels were normal. Though she developed an anaphylactic reaction, but
there is another question that hereditary angioedema due to factor 12 mutation can have normal complements like C3 and C4, and C1 esterase levels will also be normal. So
the mutation was not identified in any of those genes.
So thank you, Dr. Omer. Lesson from this is that if you develop cold-induced urticaria and it occurs early on in life, does not give you positive cold stimulation test, and there is a hereditary history, one must think of genetic etiologies of cold-induced urticaria. Thank you, Dr. Omer. We move on to third case from Dr. Hasina. Dr. Hasina, please.
Good evening to all. So I'll be presenting a case of monogenic lupus. So 16-year-old female presented with chief complaints of on and off fever for past 2 months, 2 episodes of left focal seizures 10 days prior to presentation with progressive left-sided weakness. There was no history of chronic infections such as like tuberculosis, but there was significant history of large joint painful swelling on and off for past 2 years, which resolved with NSAIDs. There was history of fever-triggered generalized seizures at 9 years of age, but she was not on any medication. In addition, parents complained that she had poor growth since childhood and did not attain menarche till date. She was born of non-consanguineous wedding. Mother had an IUD at 9th month gestation, and one of the proband female sibling, expired due to febrile illness at 6 months. She has another younger male sibling who is healthy. On examination, she was found to be in hypertensive emergency, which was managed according to protocol. Anthropometry revealed wasting. In addition, she also had severe proportionate stunting, with height corresponding to minus 5.8 standard deviation. She had sparse hair and tanner staging corresponded to stage 2. Her visual perception was poor, only to light in both eyes, with fundus revealing grade 4 hypertensive retinopathy. And she had left upper motor neurons 6th and 7th cranial nerve palsy with left spasticity and brisk reflexes. In addition, she also had firm hepatosplenomegaly. So hemorrhagic stroke secondary to hypertension was suspected, probably due to an underlying autoimmune etiology. So an emergency plain CT was done. The picture I have not shown here, but that revealed a large intraparenchymal bleed in the right frontoparietal region. So this is a proband. Her basic investigation revealed anemia, a high TLC count, and DSR was very high. Though the kidney function was normal, urine analysis revealed significant proteinuria and also microscopic hematuria. So because of these findings, we went ahead and did renal biopsy to rule out lupus nephritis after controlling her blood pressure. Her light microscopy revealed mesangial-proliferative glomerular nephritis with segmental sclerosis, and immunofluorescence revealed predominant mesangial IgA deposits, which was confirmed by electron microscopy. So this was to our surprise, where in lupus nephritis, we predominantly expect a houseful pattern of polyclonal immunoglobulin. So this was more suggestive of IgA nephropathy. So to confirm, we did autoimmune workup where ANA screening was positive, dsDNA was high, her SSA, anti-SSA was positive, APLA and lupus anticoagulant was negative with normal C3 and C4. So with this, she fulfilled the SLIC diagnostic criteria for systemic lupus erythematosus. However, in view of severe stunting and primary amenorrhea, we did an endocrinological workup which revealed hyperthyrotropinemia, and her FSH was in the prepubertal range. While reviewing her old records, we came across this X-ray which was done for short stature workup. We can see the irregularities involving the vertebral end plates. So we went ahead and did a whole skeletal survey where we identified this mild metaphyseal irregularities involving the distal end of radius and ulna. And CT, which was done at 9 years because of the febrile seizures, we can also see that this shows bilateral basal ganglia calcification. So because of all these findings, monogenic lupus was suspected, and we could narrow a differential to type 1 interferonopathy and probably spondyloenchondrodysplasia with immune dysregulation. So instead of proceeding to whole exome testing, we found that the gene causing this disorder has just 4 exons. So in-house, we ourselves designed the primers and did Sanger sequencing, where we can see that this particular patient harbored a compound heterozygous variant. One is a nonsense and another a missense in exon 3 and 4 respectively. And in silico prediction tools, protein modeling was done, and segregation in parents all were found that these 2 variants were deleterious. So this shows that genome testing can sometimes be even economical. So with the confirmation of this final diagnosis, a little bit about this disorder. It is an autosomal recessive multisystem disorder where the immunological manifestation at one end can be in the form of severe immunodeficiency, and others, and end of the spectrum, there can be autoimmune manifestation. And because of the defective gene, there is deficient tartarate resistant acid phosphatase activity, which causes impaired cartilage resorption, especially the metaphyseal end, causing the skeletal dysplasia. Whereas the autoimmune and CNS manifestation is due to excessive type 1 interferon production. So the largest case series, they also found that this autoimmune is the most common presentation, and with many individuals manifesting more than 3 types of autoimmune disorders. And even amongst those with SLE, only 36% fulfilled the diagnostic criteria for SLE. So in our case, it was a skeletal survey, which was a starting hint for further working up this case. Another interesting finding was this IgA nephropathy in patients with SLE. Only 10 cases are reported till date. And the reason in our case, probably it'd be due to her propensity to develop multiple autoimmune disorders and generalized immune dysfunction. So identification of this type of finding is very important, because we know that the management of lupus nephritis is generally immunosuppressive agents are required, whereas in IgA nephropathy, most of the time the management is conservative. So our case was also managed conservatively, and later we started her on hydroxychloroquine. So to conclude, monogenic lupus should be suspected, especially when we have atypical findings in the case of autoimmune SLE. And these individuals have to be monitored lifelong because of their propensity to develop multiple autoimmune manifestations. Thank you so much.
Thank you, Hasina. That's very well presented, how you've narrowed down to a diagnosis of SPEN-CD. Once you've got this diagnosis, is there anything else you would like to evaluate for?
So we have, this patient when on follow-up also had recurrent fever. So first actually ruled out the infectious etiology in her, and following that we have to monitor her for other neurological manifestation which can evolve over time, and also autoimmune manifestations, other type of manifestations like AITP and other Raynaud phenomenon, Sjogren syndrome, etc. So I mean, right now she has not manifested anything, but we have to monitor her for lifelong for these kind of disorders. Also, we had done I have not put the details here, but we also done an immunological profile, which in fact showed hypergammaglobulinemia.
Okay, and you must have done a lymphocyte subset analysis too at that time.
No, no, ma'am, we have not done.
Okay, thank you, Hasina. We'll move on.
You will get.
Okay, there's a question for you, Hasina, from Dr. Suma Balan. What would you consider JAK inhibitors?
Yes, ma'am. If needed, we can consider it. In monogenic lupus, they have been recently indicated.
Okay, thank you.
Thank you.
Moving on to the next case, we've got a presenter ready. Dr. Prerna Modni is going to present a case of ALPS.
Am I audible?
Yes, perfect, Prerna.
Yes. Good evening, everyone. My topic is autoimmune lymphoproliferative syndrome, a rare inherited disorder. I am Prerna Mudani from Department of Pediatrics, AGS Medical College and KM Hospital, Mumbai. Our case is a 2-year girl, second birth by order, born of a third-degree consanguineous marriage. She was brought to us with complaints of abdominal distension since 6 months of age, fever since 15 days, not associated with chills and rigors, loose stools and vomiting, which was 15 days back, which lasted for 3 days. The child had a significant past history in the form of hospitalization at 7 months of fever, 7 months of age for fever, abdominal distension, and right axillary swelling. The child was advised a bone marrow biopsy and a liver biopsy. However, the child took a discharge against medical advice. There were multiple episodes of fever and increase in size and number of swellings noted later, which were treated on OPD and IPD basis, and the child was referred to our Center for Immunodeficiency workup. There was no history of TB or TB contact, respiratory distress, night sweats, loss of appetite, weight loss, recurrent jaundice, bleeding from any site, or blood product transfusion till then. The child has a significant family history. The father is a known case of immune thrombocytopenia, thrombocytopenic purpura, and is on steroids. The birth history of the child was uneventful, and the child was developmentally appropriate and immunized till date. Clinically, on examination, the child's general condition was fair, and the child was hemodynamically and vitally stable. Pallor was present. Anthropometrically, the child's weight and height was less than -3 standard deviation. The anterior fontanelle at 2 years of age was open at level 2 into 2 centimeters, and the BCG scar was present. There was generalized lymphadenopathy involving the cervical, right axillary, and the inguinal lymph nodes. The child also had a hepatosplenomegaly of 3 centimeters and 2.5 centimeters, firm hepatosplenomegaly. So in clinical suspicion of ALPS, and also to have a differential diagnosis in the form of hematolymphoid malignancies, also other primary immunodeficiency disorders. We went ahead with a strong clinical suspicion for ALPS and worked up the child subsequently. On routine examination, on routine investigations, the hemoglobin of the child was 7.2 gram%. The total leukocyte count was 3,300 per cubic millimeter. So the child had bicytopenia. The platelets were 1.2 lakh per cubic millimeter. The vitamin B12 levels were 1,223 picogram per milliliter, which were high, and the DCT was 3+ positive. We went ahead and did a bone marrow biopsy for this patient, which was normocellular. We did a lymph node biopsy from the right axillary node, which showed widening of the interfollicular areas with increase in plasma cells. Can I have the slide, please? Thank you. There were few lymphoid follicles which were having hyalinized centers like the one which has been marked in the slide. The parafollicular region was showing many histiocytes, and these features were compatible with the primary immunodeficiency syndrome. Other than that, we also went ahead with the flow cytometry. We did a T cell receptor alpha beta positive double negative T cells, which came out to be 6.5%. More than 2.5% of the total CD3 lymphocytes is suggestive of ALPS. We did a clinical exome sequencing, which was suggestive of a homozygous missense variation in the exon 2 of the FADD gene. Hence, we found the definitive diagnosis of ALPS, which was based on 2 required criteria and 1 primary accessory criteria, which were both met in our patient. Hence, the diagnosis of ALPS were confirmed. So the final diagnosis being autoimmune lymphoproliferative syndrome. Our patient was treated with steroids and mycophenolate mofetil. We gave supportive measures in the form of antimicrobial agents and packed cell transfusions. ALPS is actually caused by a mutation in the FAS ligand pathway, where impaired apoptosis leads to abnormal proliferation of the T lymphocytes, which presents as chronic non-malignant non-infectious lymphadenopathy, hepatosplenomegaly, and multilineage cytopenias. At present, there are no curative modalities. However, initial management includes steroids and immunoglobulins. Mycophenolate mofetil, rituximab, and vincristine have shown encouraging results and have been tried. Anecdotal reports also show benefit of bone marrow transplantation. It is important that we differentiate the ALPS from hematolymphoid malignancies because they can have very similar clinical presentations.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Prerna. I just have a question. Like, this father is having idiopathic thrombocytopenic purpura. Can it be related to the mutation which he may be having, because this child has homozygous mutation in the FAT gene?
Yes, ma'am. Yes, ma'am. Actually, the father could not be worked up, but there is a very likely chance that is also an autoimmune process, because this FADD gene deficiency is an autosomal recessive disorder. So there is a possibility, but the father could not be worked up due to financial reasons.
Okay. There is a question. How has the child fared on follow-up?
On steroids, initially the child was started only on steroids. After that, the autoimmune cytopenia still persisted. The child was started on mycophenolate mofetil. After that, the autoimmune cytopenias have resolved. Currently, the child is doing well.
So if you want to give one single message to a clinician when to think of ALPS, what will be your message?
In any child presenting with generalized lymphadenopathy with hepatosplenomegaly for a chronic more than 6-month period, it is very important to have a differential of ALPS in them.
Yes, and it may be associated with certain autoimmune phenomena, like you saw in this child with DCT positive hemolytic anemia and thrombocytopenia. Thank you, Dr. Prerna. With this, we move on to next case from Dr. Rachna. Dr. Rachna, please.
Good evening, everyone. I'm Dr. Rachna Shanbag Moite, and I'm going to present a case of familial cold autoinflammatory syndrome, the first report from the Indian subcontinent. Next. A 4-year-old boy, resident of Bangalore, firstborn of non-consanguineous marriage, presented to us with skin rashes during the winter season from the age of 2 years. These rashes were macular, red in color, not associated with itching, and lasted for about 12 to 24 hours. He also complained of similar rashes on going to areas with low temperature. Next. On eliciting the family history, we found that multiple family members complained of cold-induced urticarial rashes, including his father, grandfather's brothers and sister, their children, and also the great-grandfather. The father, who's 34-year-old now, had macular rashes on the lower limbs and arms on exposure to low temperature during the winter season, followed by pain in ankles, knees, elbows, small joints of fingers, so severe that it is to limit his ability to walk for at least a week. Also, the grandfather complained of rashes and joint pains during winters, which, however, his complaints have been relieved for the past few years. There was no history of any deafness or any history suggestive of amyloidosis in the family members. So this child had a very significant family history where almost 10 members across 4 generations were involved. Next. Next. On examination, we found that the child was well looking. The weight was 13.4 kg. The height was 98 centimeters. He had multiple blanchable macular rashes on his lower limbs and on the soles of his feet. Systemic examination was, however, normal. Ophthalmological and hearing screen was also normal. So the differential diagnosis that came to our mind due to the classical presentation of cold-induced urticaria and strong family history was familial cold autoinflammatory syndrome. However, cold-induced urticaria was also a close differential. Next. On being evaluated, we found that CRP was raised. ESR was, however, normal. CBC, LFT, RFTs were normal, and immunoglobulin profile was also normal. So we sent the sample then for genetic testing. A whole exome sequencing was done, and we found a pathogenic heterozygous missense mutation in exon 3 of NLRP3 gene. The father was also noted to have the same mutation. Next. Hence, we made a final diagnosis of familial cold autoinflammatory syndrome type 1. Next. FCAS is a cryopyrin-associated periodic fever syndrome. It is also autosomal dominant in inheritance. It is characterized by intermittent episodes of rash, fever, joint pain, and other signs and symptoms of systemic inflammation triggered by exposure to cold. Onset occurs usually during infancy and early childhood and persists throughout the patient's life. It is caused by mutations in NLRP3 gene known as FCAS type 1 and NLRP12 gene known as FCAS type 2. The pathogenesis is such, next, that cold causes activation of AP1 transcription factor, which increases the gene expression of NLRP3 and also increases the synthesis of secretory proteins, which gives rise to increased secretion of IL-1 beta, giving rise to extensive inflammation. Since this was the first case in our experience, we contacted some experts. Dr. Hal Hoffman, who we will be having the privilege of listening to later this evening, has by far published the largest cohort of FCAS patients. He has published a cohort of 45 patients with onset as low as 6 months of age, with consistent symptoms like rash, fever, arthralgia, conjunctivitis, and very few patients, almost 2%, developed amyloidosis. When we discussed our case with him, he was of the opinion that he had many patients in his cohort with this kind of mutation. This mutation was associated with a mild phenotype. They regularly used IL-1 inhibitors in their patients. However, since IL-1 inhibitors are not available in India, the other treatment options could be high-dose corticosteroids, colchicine, which has been used in some patients but not with great results. Thalidomide could be used, and anakinra if available. We also contacted some other experts like Dr. Marco Gattorno and Dr. Ramanan, who also suggested that a trial of colchicine could be given in our patients. Hence, we started colchicine since it was easily available and the less toxic option amongst the treatment modalities. And we started the patient and his father on colchicine. And now they are on regular follow-up. I would like to conclude by saying that we are reporting the first case of familial cold autoinflammatory syndrome from the Indian subcontinent. Thank you.
So very well presented, Rachna. Very extensive family history, which was well taken. Are you planning to evaluate the rest of the family members?
Yes, ma'am. Since the case presented to us very recently, just 2 weeks back, so we are still in the process of evaluating the other family members.
Okay. Can you differentiate acquired cold-induced urticaria from familial one? Your case was straightforward. You had like a family history, but what if you didn't have one?
In cases of acquired, it would only be exposure to cold, and there would never be a very significant family history that we had in this particular child. Also, there would be other symptoms associated with hereditary cold urticaria, like joint pains and rashes, and these patients later on in life also develop amyloidosis.
Okay, thank you, Rachna. We'll move on to the next case. We've got Sutiraj presenting the successful outcome of an LED type 3.
Good afternoon, everybody. Am I audible?
Yes, please.
Okay. Today, I will be presenting a case report on the successful outcome of leukocyte adhesion deficiency type 3 diagnosed in the neonatal period. So we had a term, next slide, please. We had a term, small for gestational age male baby with a birth weight of 2.1 kilogram. The baby was delivered to a 29-year-old G4P3L1 with antenatal history of gestational diabetes mellitus and gestational hypertension by non-consanguineous marriage. The baby had a family history of 2 sibling deaths. One baby expired at the age of 5 hours of life with intracranial bleed, and another sibling had history of recurrent skin infections, hematuria, hepatosplenomegaly, and the child was detected to have a high count of 90,000, and X-ray also showed thickening of the end of long bones. And the baby was suspected to have a myeloproliferative disorder or juvenile myelomonocytic leukemia and succumbed at the age of 2 years. So our baby was admitted in the neonatal intensive care unit in view of these sibling deaths. And on neonatal day 3, the baby was detected to have pallor and thrombocytopenia requiring transfusion. Also on neonatal day 8, baby developed skin lesions over the groin with clinical features of sepsis. The baby also had a history of delayed fall of umbilical cord. On examination, next slide. On examination, the child was having severe pallor, high-grade fever, and there was no facial dysmorphism, but the child had bilateral inguinal pustules with light yellow pus. Also, the baby had hepatosplenomegaly. The liver span was around 7 centimeter and spleen was 6 centimeter in size. However, the child did not have any bleeding manifestations. So our differential diagnosis was initially neonatal sepsis or congenital leukemia, and we evaluated the child. On investigating, the baby was detected to have a hemoglobin of around 7.2 gram per deciliter. Total count was around 35,280. Differential count was neutrophil 72% and lymphocyte 26%, and the platelet count was 80,000. So first we did an X-ray and it showed features suggestive of osteopetrosis. There was sclerotic thickening of the long bones. Also, our peripheral smear report showed normocytic normochromic anemia with neutrophilia, and the pus culture yielded pseudomonas growth from the groin lesion. So we initially suspected a primary immunodeficiency, and we did an immunoglobulin assay in which it was normal. IgG level was 645, IgA was 27.9, IgM was 22.3, and IgE was 17.8. We initially suspected a LAD1 mutation. However, the CD11 and CD18 markers were normal in expression, and we sent a clinical exome which came positive for FERMT3 gene mutation, and hence a diagnosis of LAD3 was made. Madam, next slide. So after the diagnosis, the child underwent hematopoietic stem cell transplantation from an HLA matched unrelated donor. Post-transplant, the child had mucositis, mild skin graft versus host reaction, and severe hypertension post-transplant, but there was no features of sepsis. So I would like to conclude that LAD3 deficiency can be successfully corrected by hematopoietic stem cell transplantation if detected prior to the occurrence of any life-threatening complication, and severe leukocytosis and delayed fall of umbilical stem are very valuable clinical clues for early diagnosis. Thank you.
Thank you, Dr. Suthiraj. You have presented a really nice case where probably the elder sibling also died of a similar disease which was not picked up in time. If you want to give one single message to a pediatrician, when to suspect LAD, you have demonstrated certain things like very high leukocyte count with polymorphonuclear predominance as well as delayed cord fall. And what is the difference between LAD type 1, which is more common, compared to LAD type 3, which you are presenting today?
In LAD type 1, madam, there will be similar presentation will be there. Clinically, the child will be having similar presentations like recurrent infection and bleeding manifestation. However, the CD8 and CD18 and 11 markers will be low in LAD 1, whereas it will be normal in LAD 3. So we can differentiate LAD 1 and LAD 3 based on that.
Also osteopetrosis.
Also osteopetrosis is more common in LAD 3.
Yeah. Thank you, Dr. Suthiraj. With this, we move on to 7th case. Dr. Jyoti, please. Dr. Jyoti?
Good evening, everyone.
Yeah, you are audible. Please carry on.
Hello. Yeah. Yes, ma'am. I am Dr. Jyoti from KM Hospital, Sages Medical College, Mumbai, pediatric resident. Next slide. My topic is Grissel syndrome, type 2 with hemophagocytic lymphohistiocytosis, a rare fatal syndrome. Next slide. This is a 2-year-old girl, first born of 3rd-degree consanguineous marriage, presented with complaint of light color hair and fair. Hello. Yeah. This is a 2-year-old girl, first born of 3rd-degree consanguineous marriage, presented with complaint of light color hair and fair skin since birth, and darkening of skin noticed in 3 months of age. History of pallor since 1.5 months, and high-grade fever since 3 weeks. There is no history of cough or loose stool vomiting, no history of recurrent infection and hospitalization in the past. There is no history of similar complaint in the family, and child was developmentally normal. On clinical examination, on clinical examination, child was febrile with severe pallor. There is grayish discoloration of hair, generalized hyperpigmentation of the body seen with hypopigmented patches in between. And on systemic examination, liver is 4 cm palpable and spleen is 5 cm palpable, firm in consistency and non-tender. Other systemic examination is normal. So my differential for light color hair, silver hair syndrome will be Shady Higashi disease, Grissel syndrome, type 1, Next slide. So these 3 DDs can be differentiated from each other on the basis of hair shaft examination, microscopic examination of hair shaft under polarizing microscopy. So in Grissel syndrome, we see clumps of large and coarse melanin, irregular pattern seen in Grissel syndrome, and in Shady Higashi, we see more regular distribution of melanin pigment. And in Alagette syndrome, there is also irregular distribution of melanin pigment. So on investigation, patient was having pancytopenia with a HB of 7.7, total count of 200, and ANC count of 2. Platelets were less than 20,000. His liver enzymes were deranged, and PTINR is also deranged. TG cholesterol is 713 and 201. Serum ferritin was high. Other fever workup was sent was negative. And on bone marrow biopsy, his bone marrow is suggestive of his hemophagocytes were seen. So child was meeting 6 out of 8 criteria of HLH. So PID workup was done, immunodeficiency workup, and lymphocyte subset assay was sent, which was suggestive of B cell immunodeficiency and T cell normal. Perforin mutation was done. Perforin expression was seen on CD56 NK cells was 75. So to rule out familial type 2 HLH, there was no PRF mutation. Granulocyte release assay seen, CD107A expression on CD56 NK cells was 11, which was borderline low. And again, ruling out our familial type of HLH. Next slide. So my final diagnosis will be Griscelli syndrome. Griscelli syndrome is autosomal recessive disorder. Age of presentation is 4 months to 7 years. There are three variants of Griscelli syndrome have been identified. Griscelli type 2 is most common and most severe presentation. There is defect in RAB27A gene. Children with Griscelli type 2 develop hemophagocytic lymphohistiocytosis, hepatosplenomegaly, and lymphohistiocytosis, and combined T and B cell immunodeficiency are pronounced. It often involves impaired NK cells activity. The prognosis for long-term survival of patient with Griscelli type 2 is relatively poor and fatal within 1 to 4 years without aggressive treatment and bone marrow transplantation. Griscelli syndrome type 1 is severe neurological impairment, and type 3 there is only hypopigmented changes are seen, and prognosis is best in type 3. Thank you.
Thank you, Jyoti. Very well presented, and a very important point to take home, that it's very easy to diagnose these pigmentary dilution disorders. Just one question for you. How did you manage this child?
Ma'am, we have to manage the HLH part first. So we give steroids as per HLH criteria, but the prognosis is poor remain poor in Griscelli syndrome. So the treatment of modality is bone marrow transplantation, which was not possible in this child. A child died because of sepsis and HLH.
I think we've lost Jyoti.
Hello. Okay. So are there any more questions for Jyoti?
There's one question for you, Jyoti. Was molecular genetic testing offered?
Yes, we can send next generation sequencing. We have sent it, but the report was not came yet. Report is awaited.
Thank you, Jyoti. We move on to the next case.
Thank you so much.
So Dr. Akshaya is going to present on SPEN-CD.
Good evening. Am I audible?
Yes, Akshaya, you're audible. Go ahead.
I'll be presenting SPEN-CD, bridging the divide between autoinflammatory and autoimmunity. Next slide, please. A 4.5-year-old male presented with a history of seizures at 2 months of age. EEG and CT brain done at that time were normal. He was started on anti-epileptic drugs, which were continued up to 8 months of age and then stopped with no recurrence of seizure. Subsequently, his parents noticed that he had increasing lower limb spasticity and gross motor delay. At 16 months of age, he presented with increasing pallor and lethargy. On examination, he was in CCF and had hepatosplenomegaly. CNS examination showed lower limb spasticity with scissoring and gross motor delay. His baseline investigation showed a severe hemolytic picture with a strongly positive DCT and reticulocytosis with thrombocytopenia suggestive of an Evans phenotype, and bone marrow examination was normal. Next slide. This is his clinical picture showing TA tightness and adductor spasm. During a chest X-ray, he was noticed to have increased radiolucency of his vertebral body. Hence, his skeletal survey was done, which showed metaphyseal dysplasia of the forearm bones and platyspondyly. He was started on steroids at 2 mkd. However, an attempt made to taper off steroids was associated with increased hemolysis. Hence, he was added on azathioprine, which was continued for almost 2 years. In view of this multi-system involvement, we evaluated him further. Next slide, please. His ENA profile and dsDNA titers done to rule out other autoimmunities were normal. His TFT and HbA1c was normal. His immune workup was normal. His MRI brain showed hyperintense areas in multiple areas of the brain. His NGS showed a homozygous autosomal recessive mutation in ACP5 gene, which is associated with deficiency of TRAP protein, which reduces its inhibitory effect on toll-like receptor 9 and mid-88 induced activation of interferon regulatory factor 7. This leads to increased production of type 1 interferons and increased transcription of interferon stimulated genes. The clinical syndrome is known as spondyloenchondrodysplasia with immune dysregulation. It's a type 1 interferonopathy and falls under class 7B of the IUI's classification. It is associated with neuroinflammation because of increased levels of type 1 interferons in the CSF, autoimmunity because of increased maturation of autoreactive B cells, and skeletal dysplasia because of increased levels of osteopontin, leading to the increased resorption of bones by the osteoclast. Next slide. As there is activation of the JAK-STAT pathway in type 1 interferonopathies, many studies have shown the benefits of use of JAK inhibitors. As we are more familiar with the use of ruxolitinib and it is more freely available, we started the child on a minimum dose of 0.4 mg per kg per day. Prior to start of ruxolitinib, we did a CBC, LFT, RFT, RBS, triglyceride levels and an ECG, and they were monitored weekly thereafter. He was started on antibiotic, antiviral, antifungal prophylaxis. During the follow-up period, objective assessment of lower limb spasticity by measurement of lower limb angles showed an improvement. However, there was no control of the autoimmune hemolytic anemia, and we were not able to taper him off azathioprine. Thank you.
Thank you, Dr. Akshaya. Basically, this is the second case of the same disease that is basically showing a different spectrum here. There are a few questions to you. One question is, what does a upper segment, lower segment ratio of 0.85 signify at the age of 4.5 years? And what message do you want to give to the physicians? When should they be suspecting this condition?
So any child who presents with any autoimmunity and there's multi-system involvement, we should evaluate the child for other underlying causes. So this child had skeletal dysplasia along with autoimmune thrombocytopenia and autoimmune hemolytic anemia, and he had CNS involvement in the form of spasticity. So we evaluated him further. Also, upper segment by lower segment ratio can be variable in cases of spasticity. Some have shown short limb dwarfism, and in some cases even
I understand that because it could be related to more of spinal versus more of epimetaphyseal involvement. So thank you, Dr. Akshaya. With this, we can close the session. Thank you. Thanks, everyone. And thank you to the audience also for active participation. Thank you, ma'am. We can hand over the mic to the organizer.
Thank you to the lovely students who presented those very interesting cases and taken us from how to diagnose patients based on skeletal surveys, upper limb, lower limb ratio, hair abnormalities, and going on to how to manage them with transplant and other options. Thank you.
Thank you, Dr. Anju and Dr. Ambreen, for wonderfully conducting this session. And as you both have said, that the students have done an excellent job. And they have presented the cases so well in such a short time and given us a whole spectrum of autoinflammatory diseases. So now we'll close this session, and we will have 2 prizes in this session. So the judges will let us know who are the 2 winners. They will be announced tomorrow in the afternoon session.
Yes, ma'am. We will send you the marks.
Thank you. Thanks a lot. So we'll move to the next session now. So the next session is a very important one for all of us, and we have Dr. Deepti Suri is going to chair this session. She's an additional professor in Division of Allergy and Immunology at Advanced Pediatric Center, PGI Chandigarh. And we have Dr. Rafiela, who's going to talk to us on autoinflammatory syndrome. Over to Deepti.
Good evening, ma'am. Good evening, Dr. Gupta. It's a pleasure and it's a wonderful opportunity to have been able to participate and have this discussion on autoinflammation today. And it's my pleasure to introduce Dr. Golbak-Mansky. She is Chief of the National Institute of Allergy and Infectious Disease Translational Autoinflammatory Disease Studies at NIH USA. She leads the NIAID Autoinflammatory Disease Clinic and has built a translational research program focusing on clinical and translational studies in children with early onset autoinflammatory diseases. Her research team conducts studies on patients with IL-1 mediated autoinflammatory diseases, including NOMID and DIRA, and patients with interferon mediated autoinflammatory disease. I had an opportunity to meet her and spend a day at her clinic in 2015, and I found her to be an excellent clinician with a lot of compassion. And of course, we share a patient with DIRA, and I can assure you that apart from the diagnostics, the parents vouch for her mental and support for treatment, and she promptly replies to all of them. So thank you so much, Dr. Rafiela, for being with us today. And we are actually very keen to listen to the expanding spectrum of interferonopathies and novel insights to their pathogenesis. Thank you so much for being with us today.
Well, thank you very much. It's a true pleasure to be with you this morning. And I'd like to actually first thank Dr. Gupta and Akaval for the kind invitation to actually speak today, and actually for their defiance of these complicated circumstances this year with COVID in putting this wonderful symposium together in support of the PID network project, which I am very impressed of and very happy to support. And thank you, Dr. Suri, very much for the very kind introduction. I am talking about one area of my more recent research on the expanding spectrum of interferonopathies. And you've heard of two cases this morning that point out the importance of being able to recognize and diagnose these patients, the two SPENS D patients that were actually, let me see how I can advance. I have no disclosures. I'll talk about the role of interferon in autoinflammatory diseases, and I will focus on CANDLE, PRAS, proteasome-associated autoinflammatory disease, SAVI and AGS, and novel interferonopathies that share clinical features. I will talk about the pathomechanisms that drive type 1 interferonopathies and the interferon signature as a screening tool and challenges of treatment. Well, autoinflammatory diseases are caused by mutations. This is the landscape of the innate immune sensors on the cell surface and within the cytoplasm. And here's the nucleus. And the autoinflammatory diseases are caused by mutations in genes that encode or regulate cytoplasmic germline encoded pattern recognition receptors and their pathways. And they are part of the innate immune surveillance system. And you have heard earlier of a patient with FCAS who actually has a gain of function mutation in the NLRP3 inflammasome that constitutively or upon cold exposure leads to the release of interleukin-1 and the inflammatory syndromes. But in addition to those, there are actually mutations in the viral sensors that are coupled to the production of interferon, as well as, so this is a viral sensor, as well as proteasomes that are protein degradation units that degrade proteins, as well as mutations in nucleases that metabolize nucleic acids that lead to a whole new group of conditions that are called autoinflammatory interferonopathies and present with a high interferon dysregulation. You've also heard that immunodeficiencies with loss of function mutations in interferon signaling pathways lead to infections. Now, these conditions are thought of too much. There is continuous interferon signaling, and the presence of a blood interferon signature during active disease has in fact become the hallmark of diagnosing these immune dysregulatory conditions. So measuring an interferon score had initially been thought to be a readout for interferon that is in the serum. And interferons, when released, signal through the interferon receptor and lead to the transcription of interferon stimulated or interferon response genes. These ones are measured. But we are learning more and more that a number of the mutations that cause these interferonopathies lead to intracellular stress and signatures that basically lead to the transcription of interferon response genes that then can be amplified by interferons. So they're actually, this is still an area of investigation in these intracellular stress pathways that lead to the production of interferon response genes and interferons, and the clinical phenotype are subject of active investigation. We have two interferon systems, type 1 interferon and type 3 interferons. There are 11 interferon alphas and 1 interferon beta that signal to the type 1 interferon receptor. And then there are type 3 interferon, or the lambda interferons, that signal through the type 3 interferon receptor that is made of, it's a heterodimer. And they basically activate the same downstream pathways and lead to the production of or transcription of interferon response genes. And then there's interferon gamma, which basically drives a set of interferon gamma mediated interferon response genes. And they can be vastly overlapping, but actually they can also be distinguished at several levels. So the genes we've selected are actually response genes that are quite specific to type 1 interferon signaling, although they are partially and to lower levels also upregulated by type 2 interferons. We can quantify those in a nanostring assay, and they have actually become a fast readout for the presence of interferon signaling in these patients. Interferons drive and amplify innate and adaptive immune responses. And chronic interferon signaling is also seen in a subset of patients with monogenic lupus. Now, a typical lupus phenotype is actually seen in a monogenic form in patients who have mutations in the complement system, in DNA clearance mechanisms, or in B cell signaling. There are a number of immunodeficiencies that dysregulate T and B cell function and present with features of autoimmunity, usually cytopenias and autoantibodies. There is another group of primary autoimmune diseases that are caused or associated with disease-specific autoantibodies. And then there are metabolic conditions that again lead to T and B cell dysregulation, and some lymphoproliferative conditions that present with autoimmunity. In contrast, the autoinflammatory conditions have been revealing mechanisms that actually help us understand the actual production of interferons, and I'll actually expand on those in a minute. Now, neutrophil activation is present in both conditions, in autoinflammatory and autoimmune diseases, and the production of interferon by neutrophils amplifies both processes. Furthermore, I'd like to actually pose that the mechanisms that cause autoinflammatory conditions have been very instrumental in telling us about the organ manifestations and damage that we see in these conditions. There are candle and Savi mimics, and I'll briefly touch on those as well. But let me introduce you to the three clinical phenotypes that have helped to sort out other conditions that have more recently been found. The first disease is candle or chronic atypical neutrophilic dermatosis with lipoatrophy, elevated temperatures, and is also termed proteasome-associated autoinflammatory syndrome, or PRAS. These patients present early in life with nodular rashes that are enodosome-like on biopsy. They have panicolitis that actually causes lipodystrophy, and you can see the loss of fat that occurs usually second or third year of life. And patients have a myositis that is patchy in contrast to dermatomyositis. Many develop metabolic syndrome here with fat accumulation around the kidneys, and are very, that happens on steroids. And they have basal ganglion calcifications, which actually has become a hallmark, and you have actually seen a picture of in the ACP patient before. Soft tissue calcifications can also be present. Untreated, the mortality is 20%. Patients present with systemic inflammation. It's actually seen in most patients, and with hematologic abnormalities. Most patients have arthritis and myositis and develop contractures and atrophy, and metabolic features include hepatic steatosis that needs to be actually searched for, and insidious is the development of primary pulmonary hypertension that is present in the absence of interstitial lung disease. Neutrophilia, thrombocytosis, and later in chronic disease, thrombocytopenia and lymphopenia can ensue, and many patients have growth delay and short statures. There are a number of genetic mutations and 5 forms of proteasome-associated autoinflammatory syndrome, or CANDLE, that are known. The genes are listed here. The majority, more than 70% of known patients, have autosomal loss of function mutations in PSMB8. They are often familial and in founder populations. The proteasome mutations are linked to the ubiquitin proteasome system and lead to interferon production. The proteasome is absolutely essential, and loss of function in any of the constitutive component, or complete absence, not loss of function, absence, is incompatible with life. So the proteasome is actually like a tubule, and it has like a garbage can, an opening, and it is able to process polyubiquitinated proteins by degrading them through proteases into cleaved peptides, and they are therefore a recycling unit that is absolutely critical. If dysfunction occurs, there is accumulation of polyubiquitinated proteins in the cytoplasm. In addition to compound or homozygous and compound heterozygous cases, there are a number of proteasome components that cause the disease in a digenic disease model with a monogenic defect in one proteasome allele and one in another. And you can see there are a number of core molecules that have now been described to cause the disease, but also 2 molecules that guide the assembly, POMP and PSMG2, of that molecular tubule. The function of the proteasome is actually still under investigation. There are some early reports that the proteotoxic stress that gets released by the ER and cannot get degraded by the proteasome accumulates in the cytoplasm. That has been shown multiple times. It is unclear what the sensor for this proteotoxic stress is that actually links its accumulation to the production of type 1 interferon. And I hope that I will be able to present this to you in the not too distant future. We do know that there is an integrated stress response that can be induced by various causes, including hypoxia, metabolic disarrangements, ER stress, and so on, that is upregulated in patients with CANDLE. But again, we are missing the connections. The second proteotypic disease that I'd like to introduce to you is STING-associated vasculopathy with onset in infancy. And this disease is autosomal dominant. It mainly occurs sporadic, but can be familial in milder cases, and over 80 patients have so far been identified. Patients present early on life with rashes, usually in cold exposed areas, including the acral surfaces. And respiratory symptoms can be the presenting features in patients with less peripheral vascular disease. The peripheral vascular disease is caused by a vasculitis. You can see the fibrinoid necrosis and the infiltration of neutrophils of the vessel that gets completely destroyed. And acutely in young children can lead to acute gangrene or chronically in older patient to progressive loss of digits. The mortality is linked to the severe lung disease, and similar to CANDLE is around 20% if untreated. Hematologic and immunologic features include anemia, thrombocytopenia, leukopenia, hypergammaglobulinemia, and growth delay. The cytopenias actually occur in the context of disease flares, which is in contrast to the IL-1-mediated diseases, where usually thrombocyte counts and white blood cell counts and lymphocyte counts are stable and the others are actually elevated during flares. So that can be sometimes in early children with systemic inflammation and rashes and fever, a feature that can help you to differentiate early. There is phenotypic variability in SAVI. We recently have seen and reported 3 novel mutation in STING. The majority are actually in exon 4, but we found a family with mutations in exon 3, and the other exons that carry disease-causing mutations are 6 and 7. This disease is milder, and it had actually occurred in a mother and her 2 children. And you can see the dystrophic finger changes over time, the tapering of the fingers here on the thumb, and also the loss of tissue of the foot and dystrophic nail changes that occur over time. This is a singular case of a child with very similar features, and in both instances, there is minimal lung disease. What actually has been surprising is that the interferon signature in whole blood was negative in the 3 family members of family 2, and on multiple occasions, one time low positive in the child that I introduced to you. However, when we looked at PBMCs, we found a strong induction of the interferon response gene signature, which was mimicked by SAVI patients who actually have constitutively expressed high interferon response gene signatures. However, if you take healthy patients' blood and you compare whole blood versus PBMCs, there is no induction, suggesting that these cells may be pre-primed and may actually trigger an interferon response induced by the Ficol stress, something that we need to further understand and investigate. How does STING get activated? CGAS is a viral sensor that senses double-stranded DNA, not only viral, but also self-DNA, and upon activation, releases a dinucleotide, CGAM, that activates STING, which aggregates, translocates actually at the Golgi activates kinases TBK1 and IRF3 that translocate into the nucleus and transcribe interferon beta, which can be used as a readout of STING activity. Now, STING can also function as a sensor. There are a number of dinucleotides that get directly released from viruses and are actually present in the cytoplasm as homeostatic dipeptides, and they can actually activate the STING pathway as well. Now, this looks like a busy slide, but cryo-electron microscopy structure has solved the structure of STING, which actually allows us to place the mutations that we have observed into the STING dimer. So STING actually forms a dimer. The yellow part is one monomer and the green part another one. And this looks a lot easier. So you see a dimer that is formed, and the mutations actually occur in multiple regions. In the connector helix loop, which is in red, in a polymerization interface, where a negative regulator is binding. And recently, we actually identified a mutation in the transmembrane linker region. And what happens is, when STING is wild type, it needs to actually bind to cGAMP, and then it actually undergoes a 180-degree rotation. You see that the green part of the dimer moves to the other side, and there's release of an inhibitor, a C-terminal tail that actually binds and inhibits that move and the oligomerization. Multiple dimers oligomerize and actually then recruit TBK1, that's the kinase that activates the downstream pathway. And we found that mutations in the transmembrane region is actually supposed to be further down, release that inhibitory signal and allow the dimerization without with a rotation occurring. But mutations in the supporting arm that lead to milder disease actually allow for oligomerization of the dimer without the 180-degree oligomerization. Why is that important? Because we believe that STING is a great target that can be drugged, and understanding the activation mechanism will be important. I can tell you here, all these models shows that the mutant STING can oligomerize in the absence of a ligand. So any drugs that would actually try to prevent oligomerization by mimicking a ligand that can't activate would fail to treat our patients. So it is very important in understanding the activation pathways. I won't go much into that, but what is very fascinating is the development of interstitial lung disease that is also seen in other in a number of autoimmune diseases. And SAVI is the only among the three prototypic interferonopathies that is presents with interstitial lung disease. What happens is shown on these histo slides, which are cuts through the alveolar sac, and you can actually see the thickening of the alveolar membrane in compared to a healthy control. You can also see that there is fibrosis of the endothelial cells of the alveolar vessels that you can see here, and they actually stain with a small muscle antigen, and we believe are critical in driving the fibrosis. So in collaboration with Manfred Böhm's lab, who's made iPS cells, we've been able to derive iPS cell-derived endothelial cells that actually, when carrying the SAVI mutation, differentiate into fibroblasts. But when we repair the SAVI mutation, the cells actually maintain a nice endothelial phenotype and do not undergo a mesenchymal transition. I won't go into the pathways, but that is an exciting area and allows us to actually understand pathways that lead to organ damage. The third disease that is prototypic is Aicardi-Gouttière syndrome. Recently, 2 additional mutations have been found, so there are actually 9 forms of Aicardi-Gouttière syndrome. These patients mainly present with a torch-like disease. Torch is basically conditions that mimic toxoplasmosis or others like syphilis, varicella, mumps, parvo, HIV, rubella. CMV and herpes, and these patients obviously have sterile inflammation and are mainly seen by neurologists. They present later in life with developmental delay, with loss of developed milestones, and with a really characteristic calcifying leukoencephalopathy. So you see the calcifying deposits in the basal ganglia, but you also see a massive white matter disease, a feature that is absent in Candle and Savi, although the basal ganglion calcifications can be more discrete and similar to what we see in Candle and Savi. Patients do present with chilblains lesions, but however, they don't have much systemic inflammation, if any. The majority can present with autoimmune phenotypes and autoantibody positive, usually low titers, and intermittently they can present with pneumonitis, autoimmune hepatitis that should be sought for. That's actually quite common in that disease. And cytopenias, the most common mutation is RNase H2B. We've actually 2 patients that mimic Candle but had very mild spastic or neurologic signs, and on MRI had white matter disease, and were actually then diagnosed with Aicardi-Gouttiere syndrome. The most severe and presenting with early onset disease is caused by mutations in TREX1. This is usually the disease is recessive in most instances, except for IFIH1, but autosomal dominant milder mutations in IFAH1 or in TREX1 are associated with lupus. In driving actually interferon production in lupus. So these conditions have actually taught us a lot. The mutations are in genes that are endo or exonucleases and process self-RNA and DNA, or mainly self-DNA, but in one case also RNA. Now, what we have learned by studying the metabolism of nucleic acids is that the endogenous sources can come from many places, including mitochondrial DNA from micronuclei, from self-DNA, and you're all aware of the microbial DNA that actually enters a cell. Now, interestingly, self and microbial DNA and RNA act through the same viral sensors, through cGAS for double-stranded DNA and RIG-I actually is not shown here for RNA that actually is sensed. So STING translocates from the to the Golgi, where it actually is active, and we talked about its release or its triggering of type 1 interferon. More recently, mutations in 2 genes that actually process replication-dependent histone pre-messenger RNA. So basically messenger RNA that actually encodes histones have been shown to lead to disorganized metabolism of these histones and actually attract cGAS, which is the sensor for much of the self-DNA, and triggers an interferon response. So this was the latest addition, actually an exciting addition of genes that cause Aicardi-Gouttiere syndrome by Yannick Gros, who has done a tremendous work of dissecting the genetics of Aicardi-Gouttiere syndrome. So to summarize again, the 3 mechanisms that lead to the interferon response are simplified or exemplified by Candle, where proteotoxic stress, still waiting for a sensor, is triggering the integrated stress response and an interferon response gene signature. STING autoactivation leads to constitutive or easily triggerable STING activation and the production of the interferon signature, and the accumulation of nucleic acids signal through the viral sensors or the DNA and RNA sensors and trigger an interferon response. Let me just see. Briefly, I won't go much into treatment. This has been discussed. The current treatment of these patients is blocking interferon signaling, either through conceptualized through antibodies that block signaling at the receptor level. These are still in clinical trial, but anifrolumab has been successful in meeting its primary goals in lupus and is expected to get approved soon. But currently approved are JAK inhibitors that basically inhibit the signaling cascade of interferons. And you can see on this slide, they are not specific to the type 1 interferon receptor, but they also block signaling of interferon gamma, interleukins, and then growth hormones, growth hormone receptors or growth receptors that are concerned for the development of side effects. I won't show data, but we actually see catch-up growth. So we do know that at the levels we need to treat patients, we are not inhibiting growth, which has been a major issue. So how do they do? Again, I won't say a lot, but these conditions, the candle actually is treated best with JAK inhibitors. We can actually normalize or significantly lower the interferon signature in actually all, this was a flare in actually all or most patients significantly, and 50% normalize the signature and go into a complete remission. These are usually patients with somewhat milder disease. We can't really increase JAK inhibitors because of off-target effects. In lupus, the interferon signature stays elevated as in Aicardi-Gouttiere syndrome, but Adeline Vanderweer, who's been treating patients for a long time now with JAK inhibitors, has seen that there is acquisition of milestones, which basically has not been present before they've been put on treatment. So it seems to ameliorate the autoimmune features and stabilize the disease. This slide shows that JAK inhibitors will likely not completely treat. C-gas is not only triggering type 1 interferons, but it actually also activates NF-kappa B and leads to the upregulation of IL-6 and TNF. So the immune pathways that need to be controlled in patients are more diverse. And this actually points to a fact that STING may actually, that STING may be a quite significant target for treatment, which would actually not work in candle patients. So the pathomechanisms overlap, and what have we learned? Neutrophilic panicolitis is a hallmark of candle, and there are a number of conditions that actually do present with neutrophilic panicolitis 2. I'll briefly touch on. They are candle mimics. We've learned another lesson, and that is that proteasome mutations are also found in patients with autism and developmental delay. And while the mutations that cause candle are in the core particles of the proteasome that has the degrading proteolytic activity, the mutations that cause neurologic phenotypes are in the regulatory particle of the proteasome. So this is an exciting area, whether or not interferon in the CNS leads to this to the neurodevelopmental delay and the neurodegenerative disease needs to be evaluated. And obviously there's a lot of interest in proteotoxic stress in other conditions such as Alzheimer's and other degenerative neurologic diseases. And what we've also learned is that nucleic acid metabolism with enrichment of nucleic acids in the cytoplasm is quite neurotoxic and actually causes white matter disease through mechanisms that have only started to be looked at. And there are a number of novel mutations, all affecting nucleic acid metabolism, that present with an Aicardi-Gouttiere phenotype. So in fact, the predictions that phenotypic similarities may actually be caused by the same pathways have recently been studied in Copa syndrome, in other monogenic interferonopathies. Patients present with interstitial lung disease, polyarthritis, many of them are rheumatoid factor positive, and autoimmune phenotypes that can actually include glomerulonephritis. And they do have autoantibodies, including CNP ANCA antibodies. You can see that they develop rheumatoid factor positive erosive disease. And the lung disease has been thought to be very similar to SAVI, with patients having chronically elevated interferon response gene signature. And it's recently been found that COPI travels or traffics proteins from the ER to the Golgi, and when mutated, fails to bind to STING. And it actually needs to transport STING back into the ER to complete its to retrieve and refine its action. And without it binding, STING continues to actually signal, leading to interferon. And whether or not this is, it is quite likely that STING overactivation is triggering the lung disease in these patients as well. Why is that important? Because using a STING inhibitor would actually help. DADA2 is caused by adenosine deaminase deficiency. And I think we have to actually, I'll briefly go through this. It is actually thought to have DNase-like activity, and the interferon signature that is actually seen in DADA2 patients whose peripheral disease is very similar to that of SAVI might be caused by that. Furthermore, there is a pure cell aplasia phenotype in patients who have absolutely no activity of ADA2, suggesting that some activity of ADA2, some residual activity is necessary in order to cause the inflammatory phenotype that is responsive to TNF inhibition, but not the bone marrow phenotype.
I think we have to quickly.
I'll basically finish. I will not actually tell you about Nemo and Endas. Nemo Endas, a novel disease, but will actually go to the end. These conditions actually point to novel targets of treatment. And in summary, the autoinflammatory Mendelian diseases, including SAVI, CANDLE, and AGS, present with overlapping features and chronically elevated interferon signatures. However, the signaling pathways are more complex. The overlapping features can be partially treated and propagate immune and organ-specific inflammation and organ damage. And JAK-STAT inhibitors do an okay job, are better in CANDLE, hold the progression of lung disease in SAVI, and stabilize Aicardi-Goutieres syndrome. Safety monitoring for viral reactivation is recommended and necessary. And the intracellular pathways that lead to the interferon signature include ubiquitin system dysfunction, STING activation, and nucleic acid metabolism dysfunction that correlate with clinical features and pathomechanisms and actually have become targets for novel treatment. So thank you very much. I'd like to thank my team, my collaborators, and many of you who've been referring patients to us for treatment. Thank you.
Thank you, Dr. Goldbach-Mansky, for a wonderful talk and such simplified insights to complicated disorders. And I'll ask the organizers if I have time to take up a couple of questions.
Hey, Rafaela, thank you. You did a great job.
Great to see you.
Yeah, I'm here in person.
Yes. That's wonderful.
So just take one or two questions, I think.
So we have a couple of questions in the chat box. One is, what is the cause of basal ganglia calcification in type 1 interferonopathies? And
this is a very good question, and it's not known. So we don't know why particularly small vessels are affected. We believe that there is, these are small vessels that actually are known to undergo a lot of shear stress. We believe that it is probably small microendothelial damage that becomes most present or most prevalent in these areas. But as I said, there is very little known, and it's an area in humans that you can very difficult get to, and mice and murine models don't present with that. So it's a difficult area to evaluate, but it's a wonderful, in the context of inflammation, it's a wonderful clue to actually looking for interferon dysregulation.
Thank you so much. Dr. Marco also had a question. He said he was asking about why patients with DADA2 do not respond to anti-TNF.
Well,
why DADA2 respond to anti-TNF? That is not a typical type 1 classical interferonopathy.
I think this is a very good point, and I think there is data from Mariana Kaplan lab that that by other mechanisms, TNF is actually activated through the ADA2 receptors. So I think there is data of TNF production. I think the question is whether adding a JAK inhibitor would help some patients. But I think the point is that also the dysregulation that you see is more complex, and SAVI patients do not fully respond to interferon inhibiting drugs. The question would be whether in patients with DADA2 STING inhibitors would work, because they actually also would block NF-kappa B pathways, downstream pathways. So I think this is something to keep in mind for the future.
And a last question about BK viremia from Dr. Mehul, especially in patients who have JAK inhibitors. Do you advise treating such patients who have BK viremia?
There is no treatment for BK viruria. That's why we are quite vigilant in assessing it. We have assessed the safety of JAK inhibitors now over many years, and we have been measuring BK viral titers since 2015. Just if you follow the guidelines for transplant patients with BK viruria, they seem to be safe in patients with interferonopathies as well. So we do decrease the dose if we actually see BK viremia, which is associated with the development of BK nephropathy. In the urine, the titers can be tolerated usually at good levels. So monitoring BK viremia and decreasing the dose when present is advised.
Okay, I would like to thank
you, ma'am.
Thank Deepthi and Professor Rafaela for an excellent talk, and we have to move on. We would have loved to have much more questions. We always have questions in our mind all the time.
Thank you very much, and sorry that
Thanks a lot. Yeah.
Thank you very much, and enjoy the rest of the meeting. It was a pleasure.
Thank you. So we move on to the next talk, which is this session is going to be chaired by Professor Sonia Nityanand. She's the head of Department of Hematology at our institution. And Professor Michael Jordan is the speaker. So over to Sonia.
Yeah. Hi, Amita, and very nice to see Dr. Sudhir Gupta. A very good evening to you also. And I really thank you for inviting me to chair this session, which is going to be very interesting. Our speaker is Dr. Jordan. He's a professor at the Department of Pediatrics at the Cincinnati Children's Hospital, USA. And he's also a member of the Division of Bone Marrow Transplantation and Immunodeficiency. His area, of course, includes histiocytic disorders, and he is trying to understand histiocytic disorders and trying to develop novel therapies for them. I know it's a difficult disorder to treat. And in addition, his research interests include regulation of the immune response and immunotherapy of cancers. So we all are very much looking forward to this talk, and over to Dr. Jordan.
Great, thank you. Can you hear me okay and see my screen?
Yes, perfect.
Yes, okay. All right. Okay. Well, thank you for the invitation, Dr. Gupta and Dr. Agarwal. I appreciate the opportunity, and I'm happy to take questions and see where we go. So I'll be speaking about HLH. I'm only going to say hemophagocytic lymphohistiocytosis once. There you go. So I do have a relationship with a company whose drug I will be discussing today. In general, I'm going to really cover sort of three topics, some more in detail than others. Of course, this question of what is HLH is a recurring question, I think is still relevant. Very little about what we've learned from animal models and more from more recent clinical studies. But I'd like to put HLH in context, and I think the talk you just heard from Dr. Goldbach-Ansky was an excellent talk, and it's actually a nice sort of introduction into this context in terms of how I view primary immune regulatory disorders So some disorders I would call Mendelian disorders of autoimmunity. So these are genetic-ish problems that primarily affect the adaptive immune system and lead to autoimmunity of various sorts. There's another category of disorders that you just heard about in excellent detail. These are these autoinflammatory or interferonopathy disorders. These are disorders that are primarily affecting the innate aspect or arm of the immune system, even though they may feed back and promote autoimmunity in some contexts. And then finally, there's another group of disorders that's really distinct from these first two, and I call these disorders of T-cell hyperactivation. So they are certainly, they're primarily affecting the adaptive immune system. However, it's really not a question of specificity like the disorders of autoimmunity, but it's really a question of control of the intensity of immune activation. Now, the diagnostic criteria for HLH have been described for quite a long time now, and so I'm not going to go into the detail here. This laundry list of features has been published for many years. But really what these diagnostic criteria are pointing to and sort of trying to identify is really to identify patients with defects in this pathway. So in this granule dependent pathway of cytotoxic function, that is dependent upon perforin and a variety of other genes to help granules to be delivered to target cells. When individuals have mutations in this pathway, this is really sort of the core pattern that we see in patients with HLH. Of course, there is more genetic diversity that's been identified over the years. So in fact, you can categorize genetic lesions causing HLH into really, I would say, 4 broad categories. So one would be perforin-dependent cytotoxicity, which is the pathway shown here. But there are a variety of other lesions, for the most part much more rare, that affect T-cell signaling, but that do not impede T-cell function enough that can allow this sort of dysregulated T-cell response. There is in fact some overlap between patients with HLH and those with inflammasomopathies. And there are specific lesions affecting the inflammasome that lead to HLH in patients. And then finally, there are other genes that actually lead to intrinsic dysregulation of macrophages themselves. And this is really quite different than the other etiologies of HLH. So many years ago, we, after the discovery of perforin as the cause of HLH, we began to model the disease in animals to try to understand what's going on. And I'm not going to go into a lot of details because these are all generally published studies. But if we challenge these animals with an infectious challenge, in this case a virus called LCMV, we saw that they developed HLH. And really, to summarize things, what we found is that in addition to its previously described function in terms of resisting viruses or resisting infections, this pathway also has a really critical feedback function in the immune system. And when it's missing, it really is an essential feedback loop, the negative feedback loop that's broken. And so in a bit more detail here, you can see across the bottom papers from our lab and from other groups defining the pathophysiology of HLH in this sort of, in these animal models. And in essence, if you lose perforin, you lose this dominant regulatory feedback loop, which leads to heightened antigen presentation, particularly by dendritic cells, which leads to heightened T-cell activation, in particular by CD8 T-cells, which leads to a variety of, tremendous increases in a variety of cytokines, but interferon gamma being the most notable amongst them, which ultimately, through its ability to activate macrophages and probably other cell types, leads to HLH. And in essence, what you see is that there is a defect of immune regulation in these patients, but there's also very distinctive interferon gamma-driven immunopathology that ultimately is recognizable as the disease itself. Now in humans, the processes are the situation's a bit more complicated. And if you can imagine, there are a variety of different clinical situations in which HLH develops. The core of this sort of disease process is familial HLH, these patients that have mutations in the perforin pathway. But there also are a number of individuals that develop HLH as a complication of a rheumatologic disorder, most commonly juvenile idiopathic arthritis. But then in addition to that, there are these other situations that have been recognized literally for decades. And the first is malignancy-associated HLH. This occurs typically in older children or adults. It's increasingly recognized in adults that really, for the most part, do not have the same sort of genetic lesions that we see in children. There also is recognized HLH that can occur as a complication of various sorts of immune compromised states, either primary immunodeficiency or iatrogenic immune suppression. And then finally, even in the context of iatrogenic immune activation, for instance, with CAR T cells, patients will develop difficulties such as cytokine release syndrome that actually overlap quite strongly with the HLH we see in familial HLH patients. And so HLH is a syndrome, and this, as you might imagine, with a variety of etiologies. And in fact, like any syndrome, I think it's important to distinguish sort of the real disease process, which requires immune suppression in order to treat the patients, versus the things that I like to refer to as disease mimics. So in other words, somebody that actually fulfills the conditions of the syndrome, but would really likely not benefit from immune suppression. And this is an area that is there's still quite a lot of ambiguity and that we really don't understand. But I think we certainly see examples of patients and who meet the criteria for HLH, but in fact do not benefit or actually harmed by immune suppression. So. And in fact, another way to think about HLH in humans is that there are a variety of upstream etiologic causes for this syndrome. And what we've studied in animal models is really mostly related to familial HLH. But I think I'd like to persuade you that the commonalities amongst all these patients does suggest that, at least in the majority of them, that there is a common pathophysiology that involves T cell activation and interferon gamma, just like we see in sort of this core group of patients. Now, when we think about trying to translate this complexity to humans, it's very obvious that HLH is a disorder of inflammation. Because these patients are, by many measures, are highly inflamed. But really, when you're talking about inflammation, as you can see from Dr. Goldbach-Mansky's talk, really it can mean quite a lot of different things, right? So I like to say that inflammation is like ice cream. It comes in many flavors, and you really need to be more specific. And in particular, one problem that's been recognized for quite a long time is that patients with HLH can typically present with acute inflammation. And sometimes they can look like patients with sepsis, which is another syndrome, if you will, of acute inflammation. In the case of sepsis, what we think is that most of the time it's caused by bacterial or perhaps sometimes other pathogens. In the case of HLH, while it may be triggered by infectious pathogens, that's not really always evident. And we also know that HLH, at least in terms of familial HLH, has a very distinct sort of T cell component. So in terms of predictions from our preclinical studies and from our group and from others, is that we would predict that T cell hyperactivation, especially CD8 T cells, should be unusually or extremely prominent in this form of inflammation. It also should prominently sort of suggest interferon gamma, and in fact, interferon gamma should have a disease causal role. And so while clinically sometimes it is difficult to distinguish patients with sepsis and HLH, at least initially, we thought this would be an interesting comparison group to study. So we examined peripheral blood profiles, and I'm going to focus on T cell profiles because these were most informative, from patients with HLH, comparing them to patients with sepsis, as well as pediatric controls. And in the HLH patients, there was a mix of individuals either with identifiable familial HLH mutations or without mutations. Also individuals that had identifiable infections or those that did not have infections. In the case of sepsis, most of these patients had, but not all, had bacterial infections. And what did we find? Well, the first thing I want to point out is that we know from the animal models that HLH is a disease of T cell activation. So not so much proliferation, but actually acute activation. And the first question we wanted to ask ourselves is, what do recently activated T cells look like in humans? And this actually has been, I think, well defined in experimental studies in humans. In this case, here's an image from a 2008 paper examining individuals that were subjected to an experimental live virus vaccine, in this case for yellow fever. And what they found is that there was a very nice kinetic of appearance within, particularly in the CD8 population, of cells that were bright for CD38 and HLA-DR. And these cells came and went with a kinetic that was actually pretty similar to what we would have predicted from experimental studies. So when we looked for a similar population, and I should point out, this sort of population has also been identified in dengue hemorrhagic fever as well. And so we looked for this population in patients with sepsis or those with HLH. What we found is a very prominent recently activated CD8 population was evident in the patients with HLH, but was essentially completely missing in the patients with sepsis. And if you quantitate this across a number of patients, you can see that it's very, while there were a few patients with sepsis that had some elevations in this population, really it was the patients with HLH that had this population, whether you're gating on simply the 38 bright T cells or the 38 bright HLA-DR double positive cells. And if you perform ROC analysis, you can see that the presence of even a small population, in this case just greater than 7% of CD8 T cells with these markers, was able to very accurately identify patients with HLH from patients with sepsis or healthy controls. Now we focused on CD8 T cells in part because of our preclinical studies, but the other thing we found is that while we saw similar populations in CD4 T cells, if you actually quantitated the number of these highly activated CD8 T cells compared to the highly activated CD4 T cells, we saw that in most patients there were many, many more activated CD8 T cells circulating. And while the total number of CD8s was not really tremendously increased compared to CD4s, if you looked at the number of the ones that were highly activated, it was very highly skewed towards CD8 T cells. So again, this really mimics this really, I would say, validates our predictions from the animal models that this is exactly what we would expect. And so additionally, what about the potential role of interferon gamma? And so one thing that's worth pointing out is that interferon gamma is actually not an easy thing to measure in the blood of patients. Interferon gamma is normally secreted and acts locally. From lymphocytes are typically secreting it, and they're acting on local cell types. But in response to the local sensing of interferon gamma in the tissues, many of these cell types will produce CXCR3 chemokines, so CXCL9, 10, and 11 that bind to the same receptor. And these chemokines actually draw in other immune cells into sites of inflammation. And so they actually function at a distance. And so these are actually readily measurable in the blood of patients. And in fact, they really are a much more sensitive measure of interferon gamma activity. And to some extent, if you're looking, by the way, at CXCL10 and 11, they also would be an excellent measure of type 1 interferon activity. But when we looked at CXCL9 in the plasma of patients, what you see initially, of course, is that with inflammation, with sepsis or SIRS, there is an increase in CXCL9. So this is certainly not a specific measure of HLH. But if you compare patients with HLH to those with sepsis, there is a clear increase in CXCL9. And the other thing that's worth noting is that almost all patients with active HLH have increases in CXCL9 compared to healthy controls, sort of further validating the action of interferon gamma in HLH. And going back to the T cell phenotypes, if you look at these activated T cells that we identified in patients with HLH, and you stimulate them ex vivo, what you see is that a large number of them will produce interferon gamma. They also produce TNF, not shown in the slide here. But again, further demonstrating that the activated T cells that we see in patients with HLH are producing interferon gamma. Now, to really test the causal role of interferon gamma in HLH, you actually need to do neutralization studies like were performed in experimental animals. And in part, and this is, of course has been possible, as probably most of you are aware, is that because there was a monoclonal antibody called imapalumab, which was developed largely based on sort of preclinical animal studies. And imapalumab is a fully human high affinity antibody that binds to interferon gamma and prevents it from signaling. It has the unusual, or I would say the slightly unusual characteristic that it doesn't prevent interferon gamma from binding to its receptor. And so in the presence of high levels of interferon gamma, this antibody, which, you know, like most antibodies would at a steady state have a half-life that is approximately 3 weeks, can have a very short half-life because it will bind to the cytokine, which then binds to the receptor, and the antibody is internalized and consumed. And so it leads to some unusual aspects, like instead of dosing this antibody, say on a monthly or weekly basis, we actually will typically dose it in a highly inflamed patient twice a week. But a international study was conducted, which has been completed and now published, called the NIO 50104, and a follow-up study called the NIO 50105 study that was conducted in the US and Europe, studying children with primary HLH. Most of the patients were treated in second line. In other words, they had failed prior therapies for one reason or another. What we've found in this patient, so amongst all the patients enrolled, there were 34 patients enrolled on the study, 27 of which were treated as second-line patients. While the prognosis is not really known in second-line patients, it's generally thought to be worse than patients that don't require any kind of salvage therapy, because they demonstrate their poor responsiveness to primary therapy such as etoposide. But these patients were typical HLH patients with an median age less than a year, these patients expressing most of the typical HLH features. The disposition of these patients, so of these 34 patients, 30 patients were alive at week 8, 22 of which underwent transplantation, and 24 were alive at last follow-up. So just to sort of cut to the bottom line, what we found is that approximately a little less than 2/3 of these patients demonstrated a response to imapalumab. The responsiveness to this agent was variable from really truly excellent responses to, I would say, very, very minor responses, but clearly demonstrating that interferon gamma plays a causal role in patients with HLH. And so the other thing that I think that was good news from this study is that the long-term survival of these patients was approximately 70%. This is really was, I would say, good survival based on historical norms and based on the fact that these were patients that had failed standard therapy, most often with etoposide and dexamethasone. Now, in terms of the safety and tolerability, the other good news is that imapalumab appears to be a very safe agent. While there were many adverse events amongst these patients with HLH, this was, for the most part, was what I would say is expected amongst this population. There was one infection that was a histoplasma that led to the discontinuation of the drug, but otherwise the drug was really very well tolerated. I should point out that one of the exclusion criteria to be enrolled in the trial was the presence of a specific set of infections that are known to absolutely require interferon gamma for their control. And that includes most prominently mycobacterial infections, including tuberculosis and atypical mycobacteria, but also a few other things such as Salmonella, Shigella, and histoplasmosis. But again, confirming the prominent role of interferon gamma in HLH, all of the patients had extremely elevated levels of CXCL9 at the time of enrollment on the study. And with treatment with imapalumab, they suppressed CXCL9 levels, demonstrating in vivo interferon gamma neutralization. And also the probability, so not all patients had a complete sort of neutralization of interferon gamma despite dose escalation. And in fact, the probability of having a response actually correlated quite nicely with the CXL9 levels that the patients displayed at the end of therapy. Okay, so a word about transplantation. So the majority of these patients went on to allogeneic bone marrow transplantation. As has been known for many years, interferon gamma really has a role, or is produced in many types of immune responses, and including essentially all cellular immune responses, such as rejection, or allogeneic rejection, certainly. Experimental evidence suggests that interferon gamma would in fact have a negative impact on hematopoietic engraftment. And it's known historically that patients with HLH do relatively poorly in allogeneic transplantation for reasons that have not been fully defined. One thing in particular I'd point out is that the role of interferon gamma in GVHD is actually quite complex. There are some experimental studies that suggest that it promotes GVHD, while others actually suggest that it can suppress aspects. So it's really an unclear sort of functionality. But we did assess transplant outcomes on the NIO-50105 study. And what we found, interestingly, first off, I should point out the patient characteristics of the ones that went to transplant. This was a mix of patients receiving either myeloablative or reduced intensity conditioning regimens, as one would expect from an international study conducted across many different centers. But I think what's really worth noting is this was a relatively poor risk patient population. About half of the patients did not have matched donors. So they had mismatched or haploidentical donors. Reflecting that sort of poor donor mix, about a quarter of the patients received T-cell depleted grafts, which, as we know, actually is a risk factor for graft rejection or at least mixed chimerism. So to summarize data, really with one slide here, and that is that we observed a surprisingly excellent survival in these patients post-transplant. So approximately 90% of the children are surviving long-term post-transplant. So again, this is a relatively small sample size, and it's notable that the patients that did die were ones that, for the most part, received haploidentical transplants and did not engraft. But most patients on this study actually were able to engraft, and even with reduced intensity conditioning regimens, maintain good chimerism. And so we saw excellent survival. And while we don't know that imapalumab played a causal role because of the sample size, I think this is suggestive that that neutralizing interferon gamma will decrease complications of transplantation. GVHD, which I don't have a slide for, occurred at the expected rate, neither increased nor decreased, so probably consistent with previous experimental knowledge. Now, I'll end here with a case report, which is, maybe not as important as a prospective clinical trial, but I think it really is asks provocative questions. And so, as the community of physicians caring for children with primary immune deficiencies, I'm sure, is well aware that we know what interferon gamma is important for in humans because there are patients that lack interferon gamma receptor. There are also patients that develop neutralizing antibodies against interferon gamma. And so that was really informed the design of the prospective imapalumab trial. And these patients have increased susceptibility most prominently to mycobacterial diseases, but they also develop herpes zoster, histoplasma, salmonella infections, and a few others, but these are really some of the most prominent sorts of infections. Experimentally, we know that there are certain agents that are not really reported in patients because probably these patients are quite rare, that should be of concern, things like toxoplasma, even Ehrlichia. But there's a limited sort of spectrum of pathogens that we concern ourselves with in patients that have that lack interferon gamma functionality. But in general, we know that at least with autoantibodies, and our experience with imapalumab is that with antimicrobial treatments, these agents can be dealt with. Not so much with the patients with genetic abnormalities of signaling. But there's one patient we treated and we reported a couple of years ago now that really had quite a remarkable outcome. And so this was an almost 2-year-old child who had an EBV-associated HLH that was highly refractory to prior therapies, including rituximab. And he had persistent high-level viremia for greater than 2 months. He didn't quite meet the criteria for chronic active EBV, but probably with time he would have. But he was really dying of HLH when he was transferred to us. He had severe and prolonged pancytopenia. He had multiple infectious complications after EBV. He eventually had reactivation of CMV, had fungemia and bacteremias, multiple organ failures and injury, including renal failure and CNS and GI hemorrhages. And he was so ill that we actually treated him with emapalumab alone. We actually didn't give him steroids because of the fungemia. So he literally had only one sort of form of immune suppression. And what we observed was really amazing. And the large arrow here is where we started emapalumab. And what we saw is that within about a week and a half, his ferritin, which was essentially unmeasurably high because our lab won't dilute the serum beyond a certain level, began to plummet rapidly. And around the same time, again, with no specific therapy for EBV, his EBV levels also began to plummet. And while it did take almost 6 months for him to clear the virus, on nothing but interferon gamma blockade, he actually eventually cleared EBV on his own. And he actually recovered from the HLH and is surviving to this day without transplantation. So this result, to my mind, suggests that interferon gamma actually may impede immune responses in some contexts, including to viruses. So even though it's widely produced, I think we still have a lot to learn about what interferon gamma is actually doing in many immune responses. So to sort of summarize sort of the therapeutic landscape, historically, we have a few things that we certainly can use to treat HLH, including etoposide, as well as anti-T-cell antibodies such as ATG or alemtuzumab. Of course, corticosteroids are an essential sort of bedrock to therapy. But interferon gamma blockade is a viable treatment option. Emerging in trials ongoing, I would say, include JAK inhibitors. And in some contexts, perhaps in the case of disorders of the inflammasome, blockade of IL-18 and perhaps other cytokines as well. I didn't have time to discuss those, but those are still, I would say, being tested in humans. So HLH is really a unique type, or is a prototype of a unique category of immune regulatory disorders. This syndrome really incorporates complex patient phenotypes, probably with a variety of etiologic associations. But interferon gamma does appear to be the key driving cytokine in experimental contexts. In response to emapalumab has validated this in patients with HLH. And interferon gamma appears to contribute to immune regulation in ways that we're still unraveling. And I think that this is an area that's going to be increasingly relevant as we utilize interferon gamma blockade. So I'd like to acknowledge the team that from Novimmune and now Sobi that led to the clinical trial testing emapalumab. Additionally, individuals in my lab, in particular Vandana Chaturvedi, who did most of the flow cytometry work I showed you, as well as a number of collaborators that were essential for this work. So thank you.
So thank you very much. It was a wonderful talk, and you really, gave new insights into the pathogenesis, especially the role of interferon gamma. And, it's very interesting to see your data on, imapulumab and the outcome of hematopoietic stem cell transplantation. So it was very, very interesting, the talk. We have a lot of questions, so I'm going to go over them very quickly. So the first question is actually from Dr. Soumya Tripathi. No, sorry. Okay. So this is from Dr. Marco. Fantastic talk. Why DA2 responds to anti-TNF that is not typical for class. No, sorry, that is also. Okay, right. So this is from Dr. Sagar Bhattad. Do all patients with familial HLH develop HLH only after triggers, that is virus, or they can develop HLH without any environmental trigger?
Mm-hmm. Yeah. In common, clinical practice, I would say that many patients with familial HLH will not have an identifiable trigger. My bias is that these patients actually do have a trigger. We just don't identify it. And perhaps it's one of the many viruses that we can't measure because they really don't seem to have a clinical significance. And the reason I say that is that because perforin deficient animals that are raised in pathogen free conditions actually do not ever really develop HLH spontaneously. They require an infectious trigger. And in fact, the other reason I suspect this is that patients, so as you might imagine in humans, there are a variety of genetic lesions that range from very severe, like a real true knockout phenotype, to somewhat milder where you have sort of some residual function. And the individuals with the most severe mutations are the ones that tend to present at the youngest ages. And they also tend to be the ones in whom we're least likely to identify a trigger. But older individuals or patients with less severe mutations are more likely to have an identifiable trigger. And to me, that suggests that the patients who are true sort of knockouts for this pathway will develop HLH in response to, like I said, a variety of things that may not be measurable and that may not really have any other medical significance. So my hypothesis is they always have a trigger, but in reality that it's quite common to not be able to identify a trigger.
Thank you. And the next question is from Dr. Vaishnavi. And she has written, what is the significance of identifying heterozygous mutation in a 3-year-old child presenting with HLH, heterozygous mutation in familial HLH type 3?
Mm-hmm. Yeah. So, so that's Monk 13.4. And so, this gene in particular has been one that historically was sort of difficult to, hold on one second here. I'm actually on call today. I have to text the ICU team here. This is one, gene that historically there was, it was difficult to find all of the genetic lesions because there's a sort of a famous intronic inversion that was not identifiable by typical Sanger techniques initially. But it's hard to say for sure, but I would be suspicious that there may be another unidentified lesion that's affecting the function of that pathway. So in the US, I don't know if in India if there's a lab performing this sort of testing, but we would do, and certainly in Europe as well, we would do degranulation assays to look at the function of that pathway. We do from time to time identify patients in whom we can't quite nail down the genetic cause. We can identify a functional defect of degranulation that would, I think, validate the presence of a single allele mutation.
Amita,
yeah. Sonia, you can.
Time for more questions, or should we just wind?
We don't have time. We are already getting late, so we'll request Michael to answer the questions in the chat box because there are a large number of questions. So it will be good for the students if you can answer them in the chat box. That will be great. And thanks a lot to both.
Yes. Okay. Yes. Yeah. Thank you
for sharing the session. And Michael, excellent talk. I think we have really partly understood. Hyphen gamma is a very difficult cytokine. Yeah. So, and it has very different actions in different areas. So it's a wonderful talk and gave us a lot of insight.
Thanks, Mike.
Thank you.
Thanks a lot. He's already shared his screen, so you can introduce her. Hall has already shared his screen.
Hal, are you there?
Yes, he's already put in the slides.
Yes, I am here. And
okay, thanks for getting up so early, to take it 6 o'clock to speak in the morning. That's why I left California being here, so that I don't have to get up that early. So it's my pleasure to introduce Hal Hoffman, who is a professor of medicine and pediatrics. And he is also chief of the division of pediatric allergy, immunology, and rheumatology. He's credited with 3 gene discovery for 3 different autoinflammatory disease, and he is an avid surfer. So you might see one of the slides that he is surfing there. Hal, it's all yours.
All right, so can everybody hear me?
Yeah.
And can everybody see me?
Yeah.
And can everybody see my slides?
Yeah.
All right, I'll get started then. Well, thanks so much, Sudhir, for the wonderful introduction. Thank you for the organizers for inviting me. I have great memories of my last visit to India when I presented at the FPID meetings, and look forward to coming there again when things calm down. You've heard some really good talks this morning about autoinflammation. So I won't have to do a lot of introduction about the topic. I am going to focus on treatment. And the goal is to sort of give you an idea of how really understanding the genetic basis of these diseases has really improved our clinical outcomes. I do have a few disclosures involving companies that I've worked with or working with. And some of these drugs I will be at least briefly talking about in this talk. The other disclosure is that I am a surfer, and you will be seeing several pictures of me surfing around the world. This one is in Fiji. Hopefully in the next few months, I hope to be pretty close to India as I go to the Maldives for my next surf location. I do also want to point out this recent issue of the Journal of Allergy and Clinical Immunology, which is a focus issue on autoinflammation and hyperinflammation. I was guest editor, and I think it's really worth taking a look at some of the reviews, both on autoinflammation and hyperinflammation. And we have some really nice papers going through the classification, treatment, and also sort of just basic what it's like as an allergist immunologist seeing patients with autoinflammation. I know many of the doctors here are immunologists, and so we really, as an immunologist, I really think of all of these disorders as disorders of immune dysregulation, including some of the very common diseases like allergy and autoimmune diseases. These a little less common diseases of autoinflammation, but also all the immune deficiencies as well. And I think putting all these together makes a lot of sense. And I like the way that this meeting has been organized to sort of think about both immune deficiency and autoinflammation at the same time. I'll begin with cases. And since everyone knows my favorite disease is CAPS, talk a little bit about how autoinflammatory diseases has really been a great example of the bench to bedside approach. We'll talk about inflammasomopathy mechanisms, but mostly focus on how that has helped us understand and get to better targeted therapies. And we'll talk about current therapies as well as where we're headed in the future. And then briefly, I know you heard a lot about interferonopathies from Dr. Goldbach-Mansky, but I will briefly talk a little bit about the treatment of the interferonopathies as well. My sort of foray into this field came more than 20 years ago during my allergy immunology training here in San Diego. I met this gentleman who had a lifelong history of a daily urticaria-like rash, fever, and joint symptoms following cold exposure, much like one or two of the cases that you heard earlier today presented there. As you know, this patient has familial cold autoinflammatory syndrome, although before I got involved, it had a number of other names, including familial cold urticaria, which caused all kinds of confusion in treatment. And really before, one of the reasons I got involved in this disease was the patients, because they really were suffering and had a decreased quality of life. And they'd been seen by many, many doctors over the years and had been treated with lots and lots of ineffective therapies. Most of the patients had been giving antihistamines with very little benefit. Some took nonsteroidal anti-inflammatories, which maybe took the edge off some of the pain that they had and the fever, but not really. Some had taken corticosteroids with very little benefit until you get to super high doses. Anabolic steroids have been used with some effect, but of course, there are lots of side effects from that as well. Colchicine, which obviously is the drug of choice in familial Mediterranean fever, it didn't seem to work that well in some of these patients, although it does seem like there may be certain patients where it can work in. There was a really curious report from the 1970s where patients with this disease had been given a Pseudomonas polysaccharide complex injection. And these patients actually described being extremely sick after getting this shot of basically endotoxin, but then actually having their FCAS symptoms better over a few months. Well, that treatment didn't really last. And so what most patients did is they would just limit their exposure to cold. Many of them moved to different parts of the country. Most of them would just stay indoors. And because they've been seen by so many doctors and not really given anything that was helpful, they actually avoided doctors even more than they avoided the cold. And I think that's something that can be happening all over the world. These were the initial 6 pedigrees that we identified, and we have identified more than 25 or 30 pedigrees here in the United States. And the United States is a little bit unusual from a genetic standpoint because we have a very large founder effect. We have a founder mutation that came over in the 1600s from the UK, and then populated the country with one mutation with FCAS. There are certainly other mutations in other families, but 80% of the families here in the United States are actually have that particular mutation. What I did in order to collect these families and learn more about the disease and get DNA was these family reunions that I did all over the United States. And this shows a map of all the different places I went. You can see the large circles are greater than 10 patients, the medium circles are 3 to 9, and the small circles are 1 to 2. These family reunions were really set up by some sort of a family cheerleader. And that person would get as many patients or family members that they could get along with in one room. I would go there to visit them, tell them about the research, have them sign consents, draw their blood, and then we would have lunch. And that was what I did for a year or two to meet all these families and really learn more about this disease. And one thing you do notice is that the families do seem to congregate in the slightly warmer part of the country. You see that the majority of patients are in the southern, either Southeast or Southern California, all the way down through the Southwest. You do see some living in slightly cooler regions and very few patients living in the coldest parts of the country. You also see very few patients living in the hottest parts of the country because air conditioning is pretty much a requirement to live in those parts of the country. And those patients, really air conditioning is one of the worst things for these patients. I bring this up because I think we are still just at the beginning of understanding the epidemiology and incidence of autoinflammatory disease in India. My guess is there are many, many patients with autoinflammation, and you guys have just begun to touch the tip of the iceberg for patients. But I can tell you that going to those patients is what works for me. Sudhir has set up a number of different centers around the country, which can serve as centers of excellence, which may work just as well. The end result of meeting all those patients and collecting DNA was that we did identify NLRP3, and it turned out to have mutations that lead to what is now known as the cryopyrinopathies. It turned out that these mutations were also identified in a few other separate diseases that are now known as a continued disease. This patient here had similar symptoms to patients with FCAS, but also had some hearing loss and kidney disease from amyloidosis. And as you know, that is Muckle-Wells syndrome. And these patients had been through this same list of ineffective therapies over the years, which really led to a lot of frustration and a lot of morbidity. And finally, as you all know, the most severe form of this disease is neonatal onset multisystem inflammatory disease. And this 18-month-old child had, again, many of the same symptoms, including urticaria-like rash and fever, but really had chronic symptoms as well as some bone abnormalities, developmental delay, and significant CNS inflammation resulting in seizures. This disease, as I said, is NOMID, and these patients were really, before we had targeted therapies, were really some of the most difficult patients that any pediatric specialist took care of. And often these patients had significant morbidity from the treatments that were given that really weren't that effective. So as I mentioned, this is now a continuum. We know this is a continuum, either cryopyrinopathies or CAPS, with FCAS being the mildest, Muckle-Wells being of intermediate severity, and NOMID being the most severe. And we've identified over 90 mutations around the world that span this phenotype. One fascinating thing is that there is actually fairly good genotype-phenotype correlation, meaning that if you have a particular mutation, you can fairly predict how severe that patient is going to be. And that can also determine your therapy, as I'll explain a little bit later. We do have some mutations, and those are the ones in black, that are actually low penetrance variants, which can be seen in the general population, but at times can also lead to either very classic CAPS phenotypes or phenotypes that are different, but with inflammation or without. Identifying the gene really, and these mutations, as well as a number of different groups around the world who were beginning to study these NLR proteins, really helped to give us an idea of mechanism. And that's really what has driven the therapy for these patients and continues to drive our search for new treatments. It turns out NLRP3 is, or cryopyrin, is a component of a large intracellular protein complex known as the inflammasome. And its primary role is to activate caspase-1, or the interleukin-1 converting enzyme. Once caspase-1 is activated, it then can allow for the cleavage and activation of the immature form of IL-1 or pro-IL-1, as well as IL-18. And also the caspase-1 then allows the cleavage and formation of these gastromin D pores, which then allow for the mature form of pro-IL-1 beta to leave the cell. Once IL-1 beta leaves the cell, it then can bind to receptors on all kinds of other cells, immune cells and non-immune cells, or even on receptors on the same cell, leading to activation and then additional cytokine and expression of other inflammasome components, which can then lead to this sort of autoinflammatory cycle. In addition, you also have the expression of a number of other downstream cytokines, which can add to the cascade of inflammation and bring in additional immune cells. There's also a form of cell death called pyroptotic cell death, which is due to the activation of these gastromin D pores. So with CAPS, this normal NLRP3 inflammasome that is important in detecting pathogens and also in detecting cell stress is in a hyperactivated state. Or a much more, has a lower threshold for activation. And so these mutations in cryopyrin or NLRP3 are gain of function mutations leading to a hyperactive inflammasome, which means more active, in the case of FCAS, with a cold exposure leads to more active caspase-1 and the release of more IL-1 beta. So how has this helped us with targeted therapy? Well, obviously, you can tell from this pathway, there are a number of different ways to target this pathway. But fortunately for us, 15 years ago, 15 or 20 years ago, there were some drugs that are already available to target that therapy. And these were drugs that actually targeted IL-1 beta. And particularly, the one drug that was available was an IL-1 receptor antagonist, anakinra, which had been approved to treat patients with rheumatoid arthritis. Anakinra is a recombinant form of a natural regulatory protein in the innate immune system. And basically, IL-1 receptor antagonist binds to the receptor and prevents IL-1 beta from getting to the receptor and leading to all the inflammation, fever, and rash. So we were one of the first to treat patients with CAPS with anakinra, and we used a cold challenge model where we take our patients and put them in a cold room for 45 minutes and then follow them over the next 24 hours, watching them develop symptoms and develop inflammation. The patients that went into the cold room and got anakinra had absolutely no inflammation actually for the next 24 to 48 hours. demonstrating that targeting this pathway was effective. There were also patients with Muckle-Wells treated with anakinra, as well as Dr. Gobak-Mansky treated a number of patients at the NIH with anakinra on a daily basis with amazing results. In addition, there were a number of other companies that were thinking about IL-1 as a target, and so we worked closely with a company that made this this fusion protein known as Arcalyst or rilonacept, which is basically a fusion protein of the IL-1 receptor as well as the IL-1 accessory protein combined to an FC region in order to give it extended half-life. And so this particular protein also has high affinity for IL-1 beta, which does the same thing as anakinra, prevents IL-1 beta from getting to the receptor. This was approved in 2008 for CAPS. And then the other IL-1 targeted therapy is canakinumab, which is a fully humanized antibody to IL-1 beta, which has a longer half-life and was approved for CAPS in 2009. So we now have 3 different targeted therapies available for patients with CAPS along the CAPS spectrum. Unfortunately, it's a little bit strange in the US because we have sort of a split of how things are approved. But basically, the one interesting thing about this spectrum is all these 3 drugs work along the spectrum. And interestingly, they have different half-lives. So we give them either daily, weekly, or monthly, or every other month. Interestingly, the dosing is about the same for all of these different drugs, even though they're given at different days. So for the mild form of the spectrum, patients can get along with 0 or 2 to 2 milligrams per kilogram. The Muckle-Wells patients, or intermediate severity, can do 3 or 4 milligrams per kilogram. And the patients with NOMID require the higher doses, just showing that sort of the mutations which lead to the more severe spectrum give you more IL-1 activation, so you need more IL-1 blocking to actually get the result. Now, the approval here in the United States is actually a little bit strange because rilonacept and canakinumab are only approved for FCAS and Muckle-Wells, where anakinra is only approved for NOMID, and that's different than what goes on in the EMA, where they've approved both canakinumab and anakinra throughout the entire spectrum. So these IL-1 targeted therapies have really changed lives of patients and resulted in much better quality of life and much less morbidity and mortality. But there are issues with targeting IL-1. We know IL-1 is an important component of our response to infection. And so we do see non-opportunistic infections in patients on IL-1 targeted therapy. It's not always seen, and it seems to happen more in patients who already are having some issues with infection. But particularly group A strep, as well as staph, seem to be problems with patients that are on IL-1 targeted therapies. So we have a very low threshold for treating these patients with antibiotics. These are very expensive medications, and this has a lot of implications for other countries around the world in which this is really an impossible thing to do. What we have noticed over time is that some CAPS patients have needed increased dose over time. We've always had some patients, particularly the most severe patients, like patients with NOMID, who didn't have a complete response. And then as we've began to use these drugs in other autoinflammatory disorders, there's also incomplete responses. So this is sort of a summary of where we are now with FDA approval here in the States. Because of the cluster trial, the canakinumab was approved for FMF, HIDS, and TRAPS, although it doesn't have the same efficacy as we see in our patients with CAPS. Recently, DIRA was also approved. Anakinra was approved for DIRA just this year, and it is also pending approval for rilonacept as well. And the IL-1 targeted drugs have had a little less success in some of the other inflammasomopathies, including NLRP1, NLRP12, and NLRC4. Now, this is me surfing in La Jolla, and your concern is it a shark or a dolphin? And you can relax, it's a dolphin. But the reason for this is that we do see differences, similarities and differences in these inflammasomopathies, particularly we see differences with the NLRC4 inflammasome. And so NLRC4 makes an inflammasome just like we see NLRP3, but instead of it being primarily IL-1 beta, and instead of it being primarily innate immune cells, it seems like the intestinal epithelial cell, which makes more IL-18, is the major driver. And so there has been some success with IL-1 beta targeted therapies in these patients, but not complete success. And so there are targeted therapies like the IL-18 binding protein, another natural protein that a recombinant form has been made, which basically binds to IL-18 and prevents them from getting to the receptor. And there are trials going on right now in patients with NLRC4. So what do we do in India? Well, I think there was, a lot of promise for biosimilars. We were hoping that would be out, that a lot of these different biologics would come out and be available. I'm not sure that's really happened yet. And so in the absence of available drugs, at least the last time I spoke to you, I know there was a consideration of whether or not transplant or gene therapy was a more cost-effective way to go. What I'm hoping in the future is that there will be more options that maybe don't have the economic difficulties or availability issues that you're experiencing in India. We've spent years studying a number of natural products. Unfortunately, we haven't come up with a great natural product that blocks the inflammasome. But we spent years studying green tea as a potential inflammasome inhibitor, and there are a number of other things like beta hydroxybutyrate, which potentially can regulate the inflammasome. There are also a number of drugs out there that have been there for years and years, and no one knew how they worked, including some antihistamines like tranilast, protein pump inhibitors, which sometimes have some anti-inflammatory effect, or even some gout drugs that actually have some blocking ability of the NLRP3 inflammasome. And so it's possible that we could repurpose some of these drugs and they would be available. But I think one of the biggest focuses right now by a lot of us and also a lot in industry is the design of small molecules that could be oral medications, which hopefully would be something available at less of a cost. Although in general, even though we've got a lot of new small molecule inhibitors on the market, not for NLRP3 yet, we're not seeing them be that much cheaper. So as we sort of go back to this pathway, you can imagine a number of different ways that you could target this, this pathway. You could try to control the things that activate the inflammasome. You could try to target NLRP3 directly, and that's honestly the focus of more than 10 different companies around the world, including some in India. You could target caspase-1, although that has not been very successful in the past. I'll show a little bit of data with that. You could try to target the release of IL-1 beta by blocking gastromin D or other things that allow for the release. As we mentioned before, IL-1 beta and IL-1 receptor are already been targeted. You could also go downstream, and there's a number of different inhibitors in clinical trials which target that IL-1 receptor signaling pathway. Or you could even think about targeting some of the cytokines downstream. And so a number of different groups, including a group we've worked with, Ikelat's Labs, has used a number of different screens to try to identify small molecules that can block the inflammasome. And the results have been really amazing. And there have been a lot of good results, including identifying some older drugs that were already available, but also potentially new compounds. And so this is sort of a summary that goes through some of the different targets and places that this screen has picked up along the way, including some drugs like VX-765, which is a caspase-1 inhibitor and has been studied and has actually been given to patients with CAPS with only sort of partial success. But you can see a number of different newer compounds in here, as well as the older IL-1 targeted therapies. So we've been using a number of different preclinical models, including using our patient cells, fresh patient cells, to study these different blockers. Back in 2005, we showed that actually caspase 1 inhibition actually does block the release of IL-1 beta from PBMCs from patients. And more recently, we've used some specific NLRP3 inhibitors and showed that in some cases, those NLRP3 inhibitors are as effective in patients as they are in normal controls, but there are some situations where either the drug or the mutation shows that there's a difference between the two. We've also turned to our mouse models, including 3 of our models and then 1 of the Dr. Cotorno who spoke earlier have designed. And these mouse models have the same mutations in the mouse gene that we see in our patients. And we can use these specific knock-in mice to also study different drugs. We can take bone marrow-derived cells from either Muckle-Wells or FCAS mice. We can actually induce them in vitro. And then we see very similar effects in these cells that we see in our patient cells that we take ex vivo. We can also see the exact cold response that we see in patients with FCAS in the FCAS mice. And we used IL-1 trap in our Muckle-Wells mouse model, and it wasn't as good as what we see in our patients. And that's because the mouse model seems to have IL-18 as a player as well. And so that's why it was not that surprising to see that one of the new NLRP3 inhibitors, MCC950, did have much better effect at blocking mouse disease because it hits both IL-1 beta and IL-18. We've also used our inducible model, so not just the pups, and these are mice that we can actually get to adulthood relatively healthy, then induce them with tamoxifen and then give them medications. And this allows for orally administered drugs, which we can test. And this is actually an old drug that's been around for a long time, is no longer available in many countries because it had some issues with liver toxicity. But actually, you can see that it actually does a pretty good job of helping our very sick mice. So it's not all about inflammasomes. This is me in Nicaragua. As you heard earlier, Rafaela talked about all the different interferonopathies that have come out, and these are just a few of them. The good news from these diseases is that they are responding to JAK inhibitors, and there are lots of JAK inhibitors that are either in study or out already. The basic idea is that just like we see an autoinflammatory loop with the inflammasomes, there's a similar autoinflammatory loop with the interferons, in that you have interferons driving more interferon activation and leading to downstream inflammation. And these JAK inhibitors work at the JAK level, the JAK stat level, to prevent the activation, downstream activation of multiple different receptors. And so there are now numerous different JAK inhibitors out there. That some are less specific and some are more specific. Clearly, focusing on JAK1, at least for the interferonopathies, does make some sense. And there are some newer JAK1 specifics coming out. But we've seen definite improvement in our patients with interferonopathy on many of the JAK inhibitors. But I would like to mention, just like with the IL-1 inhibitors, there are always 2 faces to success. There's the nice face of the JAK inhibitors, which show that it can have control multiple pro-inflammatory cytokines, including the interferons, also control T-cell proliferation, which has made it a drug of choice for multiple different diseases, from anywhere from atopic dermatitis to many different autoimmune diseases like arthritis. But of course, these JAK inhibitors do have issues, and they do affect our antiviral defense. Yeah, you can have embolic events from them, and you can also have issues with hematopoiesis. So just like the IL-1 inhibitors, we need to sort of be careful with these things. Now, these are oral medicines, as I mentioned, and I would hope that oral medicines would be cheaper than some of the biologics and be more available. But they're, at least in the States, they're not much cheaper. They're still thousands of dollars a month, making it really challenging for some countries. So the take-home message is that these autoinflammatory diseases are excellent examples of translational research basically going from gene to mechanism to targeted therapy. And there are a number of current therapies that have been very successful, and as well as many promising therapies that are coming out, but again, are limited by cost availability and sometimes side effects. So I'd be happy to answer any questions.
Thank you, Hall, for a beautiful talk. And you have taken us through a list of therapies, and some of them which we don't have access to. So we have some questions here. So what is your experience with JAK inhibitors for NLRP12 inflammasome, please?
Yeah, that's a good question. So NLRP12 is tricky. We definitely see patients with NLRP12 that have disease. We also see a lot of patients with polymorphisms in NLRP12 that may or may not actually have NLRP12 driven disease. So that's one of the difficulties with NLRP12. NLRP12 is one of the, we'll give you one of the FCASs. There's now 5 or 6 of them that have been described. But also can give you very non-specific inflammatory disease, and also can even lead to some immune deficiency. So we have not actually used the JAK inhibitors yet in any patients. I think before I would do it, I would probably try to prove that there is some evidence of interferon signature abnormality. So we haven't actually done that. We have in some cases tried IL-1 inhibition, and honestly, it's been kind of iffy. We sometimes see some response, but not complete responses like we've seen in some of the other inflammasomopathies. So I think it's certainly, JAK inhibitors are a broad stroke, and may make sense. And you can certainly imagine, you can certainly see that some of the like TNF and other NF-kappa B driven cytokines might actually be blocked by JAK inhibitors.
There's another question on role of hydroxychloroquine in milder cases with its mechanism on lysosomes. Do you think it will do some good?
Yeah, we haven't actually studied that. Obviously hydroxychloroquine has gotten a lot of attention this year because of COVID. Whether or not it's deserved or not is always a question. And it's certainly a drug that's out there. We haven't tested it in our models. But I agree. It certainly has mechanisms that could affect lysosomes, and we know that lysosomes, and we know that a lot of what goes on with the inflammasome actually works in the inflammasome, and there have been some experience with things like cathepsin inhibitors and things like that, which also focus on that pathway, which do block cytokine release. So I think it's an interesting question. I don't have experience with it, and I'd love to hear if you guys are doing it in some ways by necessity, because you don't have access to the IL-1 inhibitors. It's a great idea, and I think it's something we could actually throw into some of our models and just see how it looks in at least the NLRP3 models. So thanks for the suggestion.
There's another suggestion from Dr. Abel Lawrence about purine inhibitors, P2X7 inhibitors. So they've been tested in rheumatoid arthritis. Would they be of any use in IL-1 related?
In general, I have concerns, at least for, as you saw on some of the diagrams that I showed, P2X7 is part of that sort of upstream signaling of the inflammasome. It is important in potassium, potentially also is regulating calcium, and these ions, either effluxing or influxing, are important in the activation of the inflammasome. In our hands, focusing on that pathway has not actually done much for patients with intrinsic inflammasome activation. We've played a little bit with some of the glyburide compounds that have been there, and we see limited efficacy in our mutant patients. So I think targeting upstream of NLRP3 for at least the inflammasomopathies may not be a real effective way to go. And while I think the P2X7 receptor may be a reasonable target for a lot of things that do drive inflammasome, as well as other immune pathways, I don't think it's going to be the answer for for our patients right now.
Thanks a lot for a great talk, and we have all enjoyed. And we hope to see you in India soon.
I hope so too. Thank you so
COVID
much.
is going to be behind us very soon.
All right, it's great to see everybody. Take care. Thank you so much.
Thank you. At the end, I would like to thank all the participants. We have had more than 130 participants, and gradually people are going out because it's getting late. So we'll hope to see you at 9 o'clock tomorrow morning. And we have lecture by Troy. He's a great teacher. People who have attended American College of Rheumatology meetings would know that he does this immunology boot camp, which is such a favorite with students. So please join us. And we have the whole day tomorrow with wonderful lectures, case reports, as well as quiz for all the postgraduates, which will be testing your knowledge at the end of the conference. And we have prizes for posters, case reports, and the quiz. So please join us and take part in the proceedings. Thanks a lot. Thank you, all of you. Have a great evening.